sir. And today is also we have invited Dr. Karkare sir for this interactive training program. Uh, Actually, yesterday I was in Delhi for some important meeting for collaboration with again because of this sir, we are also collaborating with another institute of Penn State. So for that meeting, I was there in Delhi. So I missed. So actually, this program has been planned and organized under our NAHEB MOU done with the Penn State in with the objective of this, you know, that this epidemiological part, it is now it is more in UG, PG, and PhD in the discipline of the VPH and allied subjects of the VPH, and to know certain latest models for the teaching faculties. Okay, we have to train the faculties first, and then it will be percolated to the other, the faculties of our university. So to train them, we have specially invited our beloved teacher and our mentor behind this project, Dr. Jera Bhushan sir, and he has accepted without any hesitation and agreed as per our convenience of our faculty, because faculties, you know that sir, we have very less faculties in our university and they have to adjust lot many. Besides teaching, they are having lot many other assignments. So as per their convenience, you have accepted. Thank you very much, sir, for accepting our invitation and conducting this very important training program. Yesterday, Dr. Mohan and Vivek is also appreciated. You're conducting this training program, and they're we willing to again collaborate in other forms of any zoonotic diseases to be conducted with our BAPSO. So with this, I will not take more time. We have 10 days to discuss all together here. So I wish the best luck for the training organizers, all the organizers, and the VPST. Thank you. Thank you, sir.
Thank you so much, sir, for your kind information and addressing the gathering. Today, that is on second day of the training program, 4th July 2023, we have 4 different topics of lectures. The first one is General Principles of Epidemiology 1. Second is General Principles of Epidemiology 2. And in afternoon session, we have a data presentation and case study with Dr. Umesh Karkare sir as a moderator. So now I think we will start with the session. I request respected Dr. Bhushan Jairao sir to start with the session. Bhushan Jairao sir.
Thank you, Rajshri. Much appreciated. Yesterday we finished the introduction to epidemiology. We talked about the history of epidemiology, and since we had some extra time on our hands, we were also able to go through the general principles of epidemiology. So today we are going to make a little difference in terms of how we present the materials. I will go and talk about the general principles of epidemiology, the second part. Then we will take a break for about 10 minutes, and Umesh and I will then go ahead and do the case study. And following which, we will then go ahead and talk about data presentation and measures of disease frequency. So that's the game plan. So we will take one thing at a time. I hope you are rested well, because we will now start crunching numbers, and we would expect to bring your computer or your calculator with you in order to do some of the math at some point in time. So with that, if you have any questions from my previous presentations, 3 lectures, I would be happy to engage you at this point in time, or feel free to drop me an email. I will definitely read it and provide my input on it. But if there's anybody in the class here who has questions, perhaps this is a good time to clear the air up before I move ahead with the things. Everybody is good. Life is good. LG? Okay, let's move on. Is this working? Yes. Okay, good. मला माझा माउस पुढे
Hello. Can online participants hear the voice, please?
Ma'am, yes.
Am I audible?
Yes, ma'am.
Thank you so much.
Yes, it. Yeah. How can you still help me move this? Or this has to be connected to something? Okay, cool. Okay, so let me bring up the kind of the different topics that we will be covering for this group of presentations. I call it as a 3-act play. So the first one that we recovered in terms of introduction to epidemiology, the history, the general principles, and today we will start off with what we call as general principles of it, the second part of it. Okay, then we'll take a break, and then we'll start doing a case study, come back to data presentation, and then talk about measures of disease frequency. So with that, so what are our learning objectives here in this particular lecture? One is to define, can we move this a little bit up? Okay, just put it in the corner. So what we will do is we'll define some of the key terms when we talk about infectious disease in epidemiology and utilize some of the terms. Next is we'll explain the concept of herd immunity and how it pertains to susceptibility. Then we will go and talk about the determinants. Okay, determinants as it relates to the agent, host, and the environment. Okay, so the key terms that we will kind of describe here with examples is to bring in clarity, especially if you're writing a paper, you're doing a presentation. What are the most appropriate terms to utilize in order to express your findings or your results or your data? So we will talk about what do we mean by exposure, what do we mean by an infection, the time course of the disease. We can look at it as an incubator period or a latent period. There's the lady who was mentioning about latent period yesterday. And then we have the agent characteristics, looking at the enemy or looking at the host. So we look at the enemy in terms of what do we mean by infectivity? What do we mean by pathogenicity, immunogenicity, and virulence? And then we'll intercompare all three of them and try and see what kind of measures or rates do we calculate in relation to these terms. Then we'll talk about the host response. How does the host respond in relation to a given pathogen? So we'll look at the clinical or subclinical aspects, the carrier stages, the natural history, and the herd immunity aspect of it. Okay. So what do we mean by exposure? Exposure means you are in proximity and or in contact. So the word here is in proximity, in closeness, or you're virtually in direct contact with the given agent in such a way that there is an effective transmission. Keep the word, I've highlighted terms here, okay? It is an effective transmission. It doesn't mean if you're in close proximity and contact, transmission occurs. So in order for the disease agent, we should see an effective transmission of the harm and then exceed the harmful effects of the agent if they occur. So the word effective transmission is very important in order to understand how well do we use the word exposure. Okay. Example, rabies through the bite of a rabid dog, malaria through the bite of an infected mosquito. If I had not used the word rabies, do you think the exposure is there? Less likely, right? The odds are lower. The same thing with an infected mosquito or a population or a swarm. So if it is deemed that these mosquito population or swarms are free of malaria, very difficult to say. If I don't use the word infected, the meaning of exposure changes. Okay? So keep that in mind. We'll then talk about the next term, infection. So there are two terms that will emerge. One is infection, another is infectivity. And you will see a little bit of overlap in how we define both of them, but each one has a different connotation as to how we use it. For example, when you use the word infection, it includes the concept of entry of the pathogen, the development, and the multiplication of the infectious agent in the body of man or animals. And the infection may be apparent, symptomatic, or inapparent. Okay? So this is the term which parasitologists love to use for some of their pathogens, especially the poise of entry, survival, and then multiplication. So it does not necessarily be associated with every pathogen, but that's one of the ways of how we look as the portal of entry into a new host. Now, here is an example that I provided here where we look at tick fever. We look at Lyme disease. Here is an example. Here we have a tick. Oops. I can. Yeah. So here is a tick on the surface of the skin. And then through its bite, it introduces the spirochetes, for an example, Burgordia burgeri. It then kind of coalesces through the skin and enters into the vascular system. So once it enters the vascular system, there are two important clinical manifestations that occur. One is when it passes through the skin, we tend to see lesions occurring. Okay, that's the first sign. But many a times when we go to a clinical setting and look for patients with Lyme disease, if we see a bull's mark, doesn't necessarily mean the tick has bitten in that pointed place. It may have bitten somewhere else, but the erythema that we are seeing here as a result of the passage through the skin is expressed in some part of the body. And some patients virtually don't express anything. Okay? So here is the way of looking at it, but one of the classical measurements of vascular changes, invasion through the skin, always associates with increased inflammatory cytokines. They will have a TNF-alpha will just burst over the scene. Then we'll start looking at presence of fever because TNF-alpha will rise the temperature. So those are some of the indicators that we tend to use in order to expect to say the presence of an infection. Again, keep in mind, this is the process. We are talking about the process of infection. Okay? Oops. So the next word is incubation period. I'm sure many of you have answered these questions 20 different times in 3 different exams. So the way we look at incubation period is, it's the incubation period is the time interval. It is the point A to point B or beyond, whatever we are looking at. It's called as an incubation period. It is the time interval from exposure of the infectious agent till the onset of the clinical symptoms. Okay? Now, when we look at the incubation period, it varies. It varies from disease to disease. For example, if you look at smallpox, it's approximately 10 days. So in other words, if there is an infected individual in a given village and has been exposed to smallpox, on an average, you would expect him to show the signs of clinical disease or the development of pock marks, the earlier signs of pustules somewhere between the 9th and the 12th or 13th day. So this is a kind of a ballpark. And you will see when you look at the list of diseases, there are diseases, for example, AIDS. It takes at least 5 to 10 years before we start seeing clinical signs, where there are infectious agents as less as 1 to 2 days that relates to influenza. Okay? So here, the incubation period tells a lot more about the disease, and we will relate this to other aspects such as infectivity and pathogenicity at some point in time later. So in terms of a pictorial demonstration, if you see, incubation period starts at the point of entry or exposure, the onset of infection, sometimes very difficult to detect. Oops. Very difficult to detect. And when the first clinical signs appear, that is what we take it as the incubation period. And perhaps many of you also have heard the word latent period. In the field of epidemiology, we would like to use these 2 words in 2 different settings. Incubation period is something that is incubating like an egg or a biological agent, whereas latency period is generally used for non-infectious agents. Okay? So let's talk about the latency period. Latency period is the time from exposure to the causal agent to the onset of symptoms that's usually non-infectious. The term latent period also refers to the time used in an interval between beginning of therapy and the beginning of response. From the time you start treating a patient or treating a group of individuals, when does the response, when does the host respond to the treatment? And then then we come to a conclusion whether the individual is cured or whether the individual, is ready to be released. But the problem here is many a times we tend to make a mistake. And that's I always tell physicians in my practice, in my group, in my diagnostic lab, is there's two important things you really need to be doing, especially if you're working with a very difficult disease. There is a difference between clinical cure and bacteriological cure. So keep in mind, a case that it's very tough to treat, bring down the infection under control. You always need to do follow-up checkups for the presence of the pathogen 1 to 2 weeks after fully being cured. Okay, that's very important for certain diseases such as leptospira, some of them that are tick-borne fevers, which may tend to relapse. So repeated examination after the clinical cure is there is highly recommended. So when we look at the two terms, latency period and latent period, again refers to from the time of exposure till we see the first clinical signs. And when we talk about treatment, especially treatment for cancer, is initiate the treatment, and once we see, don't even touch it. Okay, cool. Yeah. So let's try and understand this with some set of clear-cut examples. So when we look at about the very first example, we have saxitoxin and similar toxins that we see in shellfish. And what are the clinical effects we see? Paralytic shellfish poisoning, tingling, numbness around the lips, fingers, giddiness, incoherent speech, respiratory paralysis, sometimes death. And what's the latency period? Few minutes to 30 minutes. Okay. Then let's talk about organophosphorus. Again, it's a few minutes to a few hours. Atomic bomb radiation from the lessons learned in Japan. Leukemia was 2 to 12 years. Chernobyl, thyroid-related cancers, 3 to 20 plus years. And radium watch dial painters, they used to develop bone cancer between the ages of 80 and 40. That was the incubation period was from the time they were exposed to radium, it would take 8 years to 40 years. How did these painters get exposed to radium? It's very minute quantities, right? How do you get exposed? There's a line of ladies sitting up here wearing everything possible, and they're painting the dials. This is in the 1940s and 50s, because at that point you could put your hand over your dial and say, oh, this is glowing. Okay, this was mainly made during the Second World War, First World War. In that period, radium painted dials were very expensive. How did these people develop cancer? So we need to go and look at the process, how they would paint the needles. So they would take the what we call as the brush. It would be a very fine brush, and they would touch it on the tip of the tongue in order to make it fine enough so that then they would be able to dip it in the radium ink-like container and then paint it on the brush. Once they're done, they would go and then again sharpen the thing and go back and forth. So you can see certain occupational hazards that were not previously understood now emerges because of some simple practices that were being followed, right? So some things become very important, and that's a determinant. That's a very important determinant, is a behavioral aspect determinant, which we could have stopped if we had known, right? So keep in mind, these are some of the things that we need to connect the dots. If you're trying to create an epidemiologic picture, You need to connect these dots in terms of transmission. Next is communicable period. Now, the word communicable period is quite widely used in a human setting, but the use of this term has come down considerably. And when we talk about this particular term, it is the time during which an infectious agent, that's a pathogen, may be transferred directly or indirectly from an infected person to another person, infected animals to humans, infected person to animals, including arthropods. So here you're trying to look at what are the different pathways through which an infectious agent can go from one host to another host. Okay. Here's the word infectivity. So we talked about infection. Now we will talk about infectivity. So what is infectivity? It is the characteristic of the disease agent that embodies the capability to enter, survive, and multiply in the host. Very similar to what's an infection. But what comes next? What we are measuring here is the proportion of exposures. When we talk about infection, we are not talking about exposures. Here, we are bringing in the concept of proportionate number of exposures, okay? In defined circumstances that results in infection. And in order to measure it, we call it as a secondary attack rate. Okay? Higher the infectivity, harder is the difficult to control. So that means if the organism from a primary index case infects 10 people, and those 10 people are able to infect another 100 people, that's the secondary attack rate. So that secondary attack rate, if it is higher than the attack rate, then we know that here we are seeing a higher infectivity of the process. Okay. Let's talk about secondary attack rates. So when we talk about secondary attack rates, this becomes very important for epidemiologists to start understanding how is the disease moving in a given community? What are some of the aspects of the disease that we need to address if it is infecting more people than what it has started? What are some of the ways that we are looking at controlling it? So let's try and understand the concept. What do we mean by secondary attack rate? A secondary attack rate measures the frequency of new cases, the word is new cases, of a disease among contacts of known cases. So if you have a family of 5, if a child is infected, then the family of 5, that the remaining 4 in the family are at a risk, right? So that's what we go and calculate in secondary attack rate is what is the risk? Do all 4 of them come down sick? Do 3 of them come down sick? Or 1 of them comes down sick, okay? Because of an infected child in the house. So that's what exactly secondary attack rates tell us. This can be very important for diseases that spread from person to person, such as tuberculosis, measles, shigellosis, varicella, and COVID-19. And then we look at the secondary attack rates. How do we calculate? It is the number of contacts in the world of primary cases during the period. I gave you a family of 5, right? So that becomes the total number of contacts. And the primary case is that one single child who came sick into the family versus divided by the total number of contacts. Now, in order to appreciate this better, let us work an example through, okay? I'll leave this for a few minutes, a minute or two. You can take a look at it. And then we will interact. Okay, so shall we run through this problem? Okay, in this particular problem, what we are looking at is there were seven cases of hepatitis A amongst 70 children. Okay, 7 out of 70 children who were attending a daycare center. Each child came from a different family. That is the hypothesis that we are putting. Doesn't mean there are 2 kids from the same family in the same school. Can happen. But here we are, in order to simplify the process, we are saying each infected child came from a different family. There were 32 members in the 7 infected children, of which 5 family members developed hepatitis A. So now what we will do is we will calculate the first aspect is the attack rate, and then we will calculate the secondary attack rate. So the attack rate is nothing else but a division between X versus Y, where X represents the number of cases of hepatitis A amongst children who went to the daycare center or child care center, that was 7, versus the number of children enrolled in the daycare. We're not talking about the contacts in the daycare. So 7 divided by 70 times 100 means 10%. So the attack rate, hepatitis A, in the daycare center was 10%. Okay? So what have I done? I've talked about person, I've talked about the place, and I've not talked about time. That's missing here. So anytime we write a statement, and you will see that will start coming up, is statement should contain, for example, if this was May of 1999, I would say in May of 1999, the number of cases of hepatitis in the child care center was 10%. Okay? So it refers to person, place, and time, and gives us a numerical value associated with it. Let's switch on and talk about the secondary attack rate. So how do we calculate the secondary attack rate? In this process, we look at the number of cases of hepatitis amongst family contacts with children that had hepatitis A, and that was 5. The number of persons at risk in the family, keep in mind, this is where most of the students make the mistake. So this is what we call as the trap. They don't tend to follow this particular aspect. So keep in mind, we need to reinforce this on and on again, is the number of persons at risk in the family. What's that number? It is the total number of family members minus the children already infected. So where is 32? 32 refers to the number of family members, and 7 refers to the children that were already infected. So that comes down to 25. So the secondary attack rate is 5 divided by 25 is 20%. Okay. So here it gives us an impression, oh yes, this is spreading within the family. But if the attack rate was 2 or 3 or 4, that means there are some inhibitory factors taking place within the family that is preventing the further spread of the infection. Okay? So these numbers tell us meaning, but it has to be properly interpreted. Is everybody on the same page? Okay, now you guys will do this by your hand. So let's calculate the attack rate and calculate the secondary attack rate. No pressure. If you want to do it, you can do it. I'd like you guys to have a good time, but and then understand where things went wrong or where things went right. Okay. Okay, so I'm sure you guys have aced this answers here. It's okay, it's okay, it's okay. Don't stress them out. We'll do that at a later stage. This is the very second day. What's it?
Just take my previous. Yeah.
$38.85. Okay. Shall I move further ahead or some more time? Okay. So what is the interpretation? 38% of the students who attended the science exhibition in Pune on January 10th, 2020 were identified with COVID-19. So I have person, place, and time. Because if I don't put the time, you can interpret it somewhere differently. If I don't put the place, oh, that means it's applicable to the whole world. No, no, no. It's applicable only to that group of students in Pune at that point in time. Okay? So keep that in mind. This is very specific, and we tend to lose the meaning of the work that you have done if you don't add the attributes as it relates to person, place, and time. Okay? So secondary attack rate. Secondary attack rate is 85%. So how do we interpret it? Interpretation is the secondary attack rate for COVID-19 was 85% for the early condition once following one incubation period, that's on January 22nd, amongst family members with secondary contact who visited the science exhibition fair. So that means it is moving much faster than we wanted, right? Okay. Did everybody understand the concept of attack rate and secondary attack rates? Everybody clear? Okay, great. Now we'll talk about pathogenicity. We use this word so to make this word class sound better, use pathogenicity of this. But what do we mean by pathogenicity? So the word pathogenicity is nothing else but in very simple terms is the ability of the agent to cause an observable disease following exposure. So the clinical signs should be present. Does not have to be severe, has to be some form of clinical manifestation. Okay? Pathogenicity is measured as a proportion of persons infected by an agent, then experience clinical disease by the total number of people exposed. So in other words, here we have on the numerator, persons who develop the disease. Whereas in the bottom, we have the total number of people who were exposed. Say you go to a mall, there were 1,000 people in the mall. And then we realize one incubation period later, if your numbers are correct, 300 people came down with respiratory infections, okay? Whereas the remaining 700 did not. But the numerator will contain 1,000 and the top will be 300. So the pathogenicity kind of reflects upon the population that is exposed versus those that have expressed the disease condition. So when we look at things like rabies, smallpox, measles, chickenpox, common cold have high pathogenicity. So what does this mean?
Large number of people are getting infected.
Yes. What does it tell us in terms of the pathogen? It is a higher.
Population get exposed, that development of clinical signs are higher.
Yes, one way of looking at it. My question would be is, does this tell us about the organism or does it tell us about the host? Yes, it tells us both. It tells us both the condition of the host in the given situation and the condition of the pathogen. Both have to be expressed in the terms of pathogenicity. Okay, it's a yin yang. We are trying to measure the relationship between the two. In one case, the infectious agent has caused disease in one group. whereas it hasn't caused disease in the other. So this proportion is high, very high, that we tend to see in rabies, smallpox, measles, chickenpox as compared to. But we do see high infectivity, in fact, low pathogenicity when it comes to polio, because polio many a times, in fact, on significant portion of the time is asymptomatic. Okay, so that's when we call polio is having low pathogenicity. Okay, so everybody is an expert on pathogenicity. Let's talk about virulence. It's a very virulent organism. I just can't believe it is killing so many people. But let's try and say what actually is virulence. So virulence is the ability of the infectious agent to cause severe illness. And this is measured by case fatality. And it's also called as proportion of severe cases amongst those infected. But when we look at the numbers, how do we compute the numbers? The numerator includes those individuals that have died or have severe outcomes, in other words, hospitalized, whereas the bottom denominator is the ones that are infected but have not required the additional attention or medical intervention. So here, this is the way we compute virulence. Okay? So in case, for example, Ebola is a very high case fatality rate and would be considered a very virulent disease. In other words, if people are exposed to Ebola, most likely the outcome is death. So the virulence will be very high when it comes to Ebola. Okay, now I'll make your life a little bit more complicated. Now we will compare infectivity, we'll compare pathogenicity, and we'll compare virulence. And leave this few minutes for you to kind of soak it in before we move on to the next way and talking about these things. It's nothing else but the materials which I shared in my earlier slides I've composed. Keep in mind, what are we talking about? Look at these numerators and denominators, how they change as it relates to the type of terminology that we are using. So we looked at infectivity and we appreciated the definition of it. That's the ability to enter, survive, and multiply. The proportion of exposures is defined in circumstances that results in an infection. Higher the infectivity, harder to control the disease. So how do we determine infectivity? Divided by the course. What pathogenicity? Observable cases, okay, that have experienced a clinical disease. So in the numerator, we have those that have developed the disease that are symptomatic, divided by the total number of people who were exposed. What about virulence? It takes the next higher level is where the numerator includes the number of people who died and had severe outcomes as being hospitalized versus the number of people who were infected. Okay? Take the example of COVID itself. If you got COVID, you were really sick, you went to the hospital. But if you could manage at home, you still are in the denominator. You're not excluded. You're a part of the picture. So keep that in mind. Usually people tend to question, what do you mean by infected? So COVID gives you a better idea in terms of understanding what we say as virulence. Okay, so everybody online with this? Okay, let's move on to the next aspect. Here, I would like you guys to start talking and I'll keep quiet. Yep. Morbidity is in the virulence aspect. That's how we calculate. Infectivity, those are two different terms. Okay, so infectivity doesn't mean mortality. You can look at the definition of infectivity. Probably you came a few minutes late, so I covered it. I can sit with you again. Yeah. Okay, so let's start off with one side of the table. On the first column, we have the severity of the disease that has been lined as high, intermediate, low, and very low. And the following subsequent three different columns, we have the term infectivity, pathogenicity, and virulence. Okay. And how do we measure infectivity? It is the secondary attack rate. It is the ratio between the sick and the exposed, whereas pathogenicity is the ratio between the illness rate versus the number of individuals in the population. Case fatality is total number of severe cases divided by the total number of cases. And anybody would like to start with rabies? Why? Can anybody tell me why is the severity very low and the infectivity low? Direct contact. Right. Another way of looking at it is even let's take with a human being. If the human being has rabies and you're in close contact, you're not going to acquire it. Okay. So that's the reason we have the infectivity to be very low. Let's follow rabies to the next column. If you are bitten by a rabid dog and you don't get the prophylaxis in time, the pathogenicity is 99%. That means you get bitten by a rabid dog and you don't have treatment. Allah ko, you have to say, I'm coming to your gates. Right? That's the way of looking at it. So those are the various ways. Now, when we talk about virulence, boom, game over. Yeah, right? So let's take one on the high side here, smallpox. So what is smallpox? If you are exposed to smallpox, you will show signs of disease. Okay? Very high exposure, almost relates to 50% of the population would at least show initial clinical signs of disease by the 12th day, which we assume to be the incubation period. And if you're infected, you will show the clinical signs, or in terms of virulence, it's 90 to 100%. There is one interesting one here, which runs from the top to the bottom. Chickenpox. Chickenpox. Chickenpox is, if you go to a school, if a child has chickenpox, you can be assured the rest of the children in next 1 week's time will all be developing chickenpox. So it's very high. The pathogenicity is also very high in certain populations. We need to be very clear about it. In certain populations, it tends to be very high of severity of the disease. Whereas when you look at virulence, it has a very low rate of virulence. Expected mortality due to chickenpox is about 0.3%. Okay? So when we use these terms, you need to know as it relates to the disease. So you just cannot generalize the terms infectivity, pathogenicity, and virulence all at the same time. You have to dissect the process and see how we can assemble an epidemiologic picture using these different terms. Okay, immunogenicity. It's any questions? Okay. Immunogenicity. It's the ability of the organism to produce an immune response after an infection that is capable of providing protection against reinfection. So in other words, induction of lifelong immunity. I'm not very comfortable using the word lifelong immunity. There's nothing like a lifelong immunity. There is immunity for a certain period of time. And to say a lifelong immunity is a little bit of a stretch, but we will take it, right? So what are these lifelong immunity ones? Measles, polio, hepatitis B, rubella. But there are some that are weakly immunogenic in this area, gonorrhea, plasmodium, falciparum. So in other words, when we talk about immunogenicity, what is the normal process? Can I use the whiteboard? So when we talk about the process of immunogenicity, especially with Neisseria gonorrhoeae, or you're looking at mycoplasma, or you're looking at a gram-negative organism, for example, what happens? Let me draw a bacteria up here. And when these epitopes are expressed, when these different epitopes are expressed, they are antigens, right? And it is the host that recognizes these regions around and kind of chops them off and produces an antibody towards it. But it so happens, especially with Neisseria gonorrhoeae or mycoplasma, it is able to shift the expression of the antigens on the surface. Okay, so it is able to invert some expressed antigens and reverse the other antigens. So therefore, we are unable to get a complete immunity towards it. So for example, when we talk about mycoplasma, it expresses 7 different types of lipopolysaccharides. The most prevalent is C, and once you keep on working with it, it'll shut down C and start expressing D and F. And your vaccine that you produced against C is no more effective. So complementary wise, that's where we started suffering with when we looked at Streptococcus pneumonia, which is a serious issue, especially in the elderly. They developed a vaccine with 7 different carbohydrate moieties from these pneumonia. They've put 7 in them, but over a period of 3 years of using that vaccine, they started seeing the vaccine's efficacy started dropping. They realized they had forgotten 5 more epitopes that needed to go into the mixture. So now it is called as Prevnar 13, which contains 13 different polysaccharides of different Streptococcus pneumonia in one vaccine. So you can see it is immunogenicity is a little tricky to work around with, especially when we try and talk about in terms of epidemiology. Okay, herd immunity. I'm not going to spend much time here. Clear curling it. Thank you. Yeah, got it. Yeah. Okay, got it. So here, the herd immunity, I don't need to talk much about it because we have all experienced and we have been you're all experts on herd immunity. But what we really would like to say is move away from our COVID concepts that we have been largely exposed to in recent years. Let's talk about in a real life setting. For example, rubella vaccination is mandatory, right? So in case of rubella vaccination, if all the children who could possibly transmit the disease to expectant mothers are immune, the expectant mothers will protect even if their antibodies are low. So here you can see it is nothing else but these vaccinated children providing a cover for the expectant mother, because there's no other place for the virus to settle in and cause an infection. And why rubella? Rubella is also causes neonatal type of tumors. Okay, so that's what we are really concerned about. Neurological signs and neonatal tumors are associated with rubella. Okay, let's talk about determinants. So when we look at the factors that influence the distribution are called determinants. Okay, so we will talk about the agent, we'll talk about the host, and we'll talk about environment. Why is this very important? To talk about environment, agent, and the host at the same time in terms of epidemiology? Take a guess. Just take a guess. We have to talk about all three of them at the same time. Okay, so we will have to talk all three of them at the same time. Any thoughts? Why do we have to talk all about them at the same time? Yes, very good start. Yeah. Can anybody give an example?
Metasulfuria, then the existence for the metasulfuria, it needs some acids.
Hmm.
So it will make it stable or capable of infecting.
Okay, great. That's a good way of looking at it. But how would you visualize that in terms of an intervention strategy? Right? You're talking about the mechanistics. But here we are talking about the agent, the host, and the environment in terms of developing intervention, prevention, control strategies.
Either we have to improve host defense or we have to improve the environment.
That's the right approach. So anybody can give, that's really a nice approach. So can anybody give an example? What's it? Yes, that's one aspect. What else?
Exposure to the agent.
Yes, exposure to the agent. But give me an example of a disease.
Common cold is quite the example. The winter season and moderate good host immunity is also there. So yeah.
Right. Yeah. Could be one. What else?
Infectivity is depends on
Okay.
the type A, B, or C.
Okay. Any other?
Can understand the mosquito cycle. We can understand host bearing and environmental relations.
Give him a round of applause.
For
Yeah.
example, some mosquito-borne diseases, particularly malaria.
Yep.
So,
Spot on.
marine condition is there, but definitely there will be the chance of getting. And host and environment is here playing very important role. Host is always there. So, in that particular season,
So let's use your malaria as an example. So when do we see malaria? Malaria is seen during the monsoon season. And what happens to the environment? Water accumulation, potholes, right? And what does that give? It gives an opportunity for the mosquitoes to multiply. So if you were working for BMC, what would you do? You would prevent those potholes. So the very first intervention is rectifying the environment in order to prevent from the host from establishing itself. Now, when we talk about the host, what can the host do? Sleep in a mosquito net, right? Or use repellents. And if they're at a much higher risk, they can take a dosage of a given anti-malarial for a certain period of time if they're in a high-risk area. So those are some of the interventions that we can do. Now, when we look at this epidemiologic triangle, when systems are in balance, they tend to be fairly equilateral. But what happens if, oops. What happens if the triangle changes shape over time? How do we measure the rates of change or the rate of change of X over Y? Okay. This is what we measure. For example, I made changes to the environment. So what happened? It allows us to control the host. It also allows us to control the agent, both ways. In other words, if I have a vaccine, how would you look at it from a vaccine point of view? You protect the host, right? That's one of the most beneficial aspects of public health is vaccines. So when we look at vaccines, the childhood vaccines that are now available has reduced mortality rates, what we used to see 50, 60 years ago, hardly any. So childhood vaccines have improved not only the life expectancy, but also the quality of life. So it largely depends on the given disease and which is it much better to target. So is there any disease that we have to target all three areas in order to make a change? Rabies? Yep. Yes, that's a good way of looking at it. But when we look at polio, we also require a very effective environmental control, which are not that very well established, especially in lower socioeconomic settings. It is a significant investment in order to make changes to the environment, unless and until somebody gives them the money to do it, right? So, and you're right, environment plays a very significant role in control of polio. Okay, any other thoughts, any other ideas? How do you do salmonella here? Leptospira is a good one, but unfortunately, we don't have very effective vaccines in humans, right? We can control the environment, we can do all of the barriers we can put up, but yeah, but we also have humans who are sitting on the other side of the fence. So, yes, yeah. Hepatitis has a fairly limited environmental role. So let me talk about a condition which is overcrowding in prisons. So what happens when we have overcrowding in prisons? Tuberculosis, and put them under isolation or quarantine. What about the host? We revaccinate. In some cases, if they are negative for the MAR2 test, where the skin test, we can revaccinate them or put them on treatment, extended treatment for 2 years, right? So that's how we take care of the host on the other side. Does this make sense? So when we look at it, we have to look at it from several different aspects as to how best we can control an infectious diseases based on the agent. Again, this is the previous slide, I think. Oh, I canceled the point. It'll work. Let's see. Okay, good. Okay, so this is where we were. So if we manipulate based on the natural history of the disease, we will be able to do interventions either at the host level, either at the environment level, or at the agent level, okay? And if we are able to find interventions that work across all of those three, then we are able to virtually contain the disease to a given geographical area. Yep, next is the agent. So when we look at the infectious agent, when we look at it in terms of the host range, the more host it infects, less likely we have the chances of eradicating the disease. We can control the disease, but eradicating the disease becomes extremely difficult. For example, salmonella. I don't know, I mean, I started working on salmonella here in Bombay Veterinary College somewhere around in 1982, and I still work on salmonella. And Paturkar was my TA who used to help me isolate salmonella from samples that we bought from markets. So those were the days when we started working on salmonella here. So salmonella affects a variety of species across, whether it's invertebrate, vertebrate. So extremely difficult to control. Whereas with foot and mouth disease, we have better chances, okay? because we know it affects cloven-footed animals. With proper surveillance programs, vaccination programs, we should be able to eradicate foot-and-mouth disease in countries that are still having an endemic issue with this virus. Another is genomic influence or change. As I mentioned, changing of the surface epitopes. Okay, that's what we call as antigenic stability. If you look at the distemper virus, going back 60 years, that organism hasn't changed a bit. So even the vaccine that was previously made some 30, 40 years ago is still working very well because there is no change in the epitope. It's a very conserved virus, so that works in our advantage. Whereas when we talk about the influenza virus becomes very tricky, especially when it expresses 9 different types of H and 16 different types of N. The combination of N's, H and N's makes it a nightmare for an epidemiologist to come and say, for the next year's vaccine, what strain should I select? Okay, so that becomes an issue with influenza virus when we talk about antigenic stability. Next is viability, ability to withstand environmental stress. Leptospira, you know, leptospira can stay under certain conditions, not for extended period of time. But we definitely know Clostridium tetani can stay for ages, for a very, very long time, with recorded histories of going back to 60 to 70 years. So we conducted a study along a river close to Penn State, where the river would have tanneries, because for a tannery, you require a lot of water. So there were tanneries all along the river. And we gave a project to the student and said, hey, why don't you go and do geomapping and collect soil samples from the historical data going back to 1880s and identify where some of these tanning companies were located along the river, and go and collect soil samples and bring it back. Believe it or not, we picked up tetani, we picked up anthrax spores too. So this is not something unusual. It's an occupational hazard. Even after the industry goes away, still is retained somewhere at some point in time. So especially when I'm talking about the viability in environment. Next is, in terms of immunogenicity too, it's much easier to mount an immune response against Clostridium tetani as compared to Salmonella. Another aspect that we can look in terms of the host, we talked about the agent, let's talk about the host. Sickle cell anemia, what is so very unique? Of course, these people suffer, but what is the other advantage these people have imposed on themselves? They have a specific advantage as compared to the rest of the population. Malaria, yes, they're less susceptible to malaria. Okay. Age, we know age has the immune response has a dynamic effect on the age. Or the younger you are and the elderly you are, you're more likely to be immunocompromised at some point in time. So age becomes a factor. Gender, there are certain diseases that we tend to see in males as compared to females, that largely being occupation related. Okay? Men tend to work outside more as compared to females. I'm talking in an agricultural setting. So don't mistake me. In an agricultural setting, most of the work that is done on the field is done by men with heavy machinery, whereas most of the work that is done on barns or in poultry farms, generally done by women. So even if you tend to see there is a dichotomy of the diseases that are expressed between the genders. Okay? Physiologic state becomes very, very important. Prior immunological experience, that is maternal antibodies, immunization, prior exposure, intercurrent or pre-existing conditions. This is something that we had to wrestle with some of our projects in Tanzania, where we were sampling the Maasai population. We were talking to them, collecting samples, and many of them had comorbidities. In addition to having TB, they would either have HIV or have tuberculosis. So comorbidities becomes very difficult to kind of bring them into a study, because you're inducing biases or confounders in the process. Because if you're strictly looking at TB and this person also has HIV, the HIV complicates the issue of the measurements that we are doing on the individual. So we need to be very clear when you enroll a test subject into the study, see to that they are free of the diseases that we generally would tend to expect in that given population. Okay. Then human behavior, food handling, diet, hygiene, recreation, and use of other resources can play a very significant factor. Again, non-specific, I will not go much through this. This is what I would say is pretty much, if you have done the course on immunology, I will not spend much time on this here. And I would like a parasitologist here or parasitologist here to talk about this slide. Anyone? What are we seeing here? Haemonchus is there, and what's the next picture? So what do we call that barber pole worm? So barber pole worm, generally when we do a necropsy and look at the tissues, it is embedded in the submucosal region of the stomach, where it is able to attach to capillaries and draw the blood. A very chronic infection leads to the very first diagnosis. This absolutely pale in color, right? So if you're walking through a herd and you suspect that there is a gastrointestinal infection, especially in goat, sheep, and goats, it will be there. You just can't discount it. It's just by looking at their eyelids, you will be able to get a sense what's the level of the infection in a given herd. Yes, you can take a fecal sample and do a fecal count and do the measurements, but this is one of the ways to say, yes, I think we need to be also looking for something else. And how do you pick these animals up? Say, eeny, meeny, miny, mo, okay, I'm going to sample you. You make them walk, put them on the pasture. The ones that are leading at the back become ideal candidates for sampling, okay? Because they don't have the enough drive or the energy as compared to their peers to be in the group. So they are lagging behind. So they became ideal candidates for testing as such. Right? Okay, so here in terms of when we look at environmental factors, macro environmental factors such as geography, mountains, pasture lands, rivers, and more, all of them are defined by their own ecosystems, okay? Their own ecology. So as a result, ecology can be influenced, the disease outcomes can be influenced by the ecology of the place. Air pollutants, we tend to see air pollution exacerbate existing problems. For example, people with tuberculosis, and they're exposed to very high levels of poor air quality. That's what we found with some of the studies that were being reported from Lima in Peru, where XDR, tuberculosis, is rampant. And along with that, they cook with coal or with wood in very small houses. In such conditions, not only their lungs are damaged, but it further increases the pathologies of the TB that they're seeing in those houses. So you can see how things can compound in the process. Essential nutrients, vitamins and minerals, naturally occurring antimicrobials in terms of nutrition, housing that protects from harsh temperature, housing of animals without adequate ventilation. And this is one of the most common things that we tend to see here when I do my visits in Pennsylvania on dairy farms. And some of the farms are built in 1910, 1920 with very small windows. And during the winter, what do? They close the windows and keep their calves inside. And the first thing that comes up, respiratory infections. This just jump out of the roof. And that's where we tend to see issues with mycoplasma pneumonia, okay? Or pneumonia coming up with things like Pasteurella and others. So by modifying the environment, we can reduce the incidence of respiratory infections in these animals. So when we look at management, natural ecosystems, when we look at natural ecosystems, there is a kind of equilibrium between the host and the parasites. And people who do grazing or people who are in the business of grazing or nutritionists, they say that we graze in a given area for a certain period of time. Do not go back onto that land again and then go to another place to pasture. Okay, within plots, you create pasture plots. So in the process, what are you doing? You're allowing the eggs that are coming through these fecal material dry off due to with the help of the change in the weather. That will dry off or will become, or the counts will go low. That's the way we use it. The counts will go low and would be more favorable to bring back the animals 6 months or 8 months later and put them on those pastures. So those are some of the natural interventions that we can do. Next is epidemics usually occur when population increases past a certain point. What happened in Surat in 1995? Plague. And why did plague occur? Because of overpopulation in those given areas. So the density of population was estimated to be close to 1,600 or 1,700 people per square kilometer. So the density was very high density, and the opportunities were provided because first, the regular garbage wasn't removed for 3 weeks. There was a high density of population, and then there was an outbreak of plague. It doesn't mean rats don't carry. Rats are normal reservoirs, but for it to emerge in large numbers, because food is available, their numbers grew and their access to humans also increased over time. So man-made ecosystems, changing the ecosystem by civil engineering. What do? Predators are eliminated and sick animals are allowed to survive while excreting the organisms. Introduction of foreign species into new ecosystem and intensive agriculture on limited acreage. So about the civil engineering part, has anybody been to Egypt? Anybody? Cairo, Aswan, a little further up, Aswan Dam. So the Aswan Dam, which was built, I hope I can work on it, that was built to control the flooding on the Nile River. That was a major engineering feat that was undertaken in Egypt in the late 70s, I would say mid 70s to early 80s, built with Russian technology. So it's a very impressive dam, one of the highest dams in that given region, called as the Aswan Dam. The purpose of this dam was twofold. One is to provide water for agriculture. Another is to prevent seasonal flooding. Now, when we look at the process, when the dam was built, prior to the building of the dam, schistosoma infections was always under less than 2% in the given population. So after they built the dam, 2 years later, it increased close to 20%. What could be the reason? Let's go around the room. I got some great ideas. Yeah, go ahead. So why should the intermediate cost increase? But why should it increase? Slow flowing water. Yes, slow flowing water allows the snails to attach to the surface of the banks of the river. And in order to improve agriculture, what did they do? They constructed canals. And what would people do when they constructed canals? They would come over the weekend and have parties, right? So when we look at the interaction between the slow flowing water, things to control the flooding in the dam, something unexpected happened. We started seeing an increased rise of schistosoma infections in humans, right? So you can see we made the problem without knowing it, right? It's an interesting way of looking at it. Now, if you were to develop as an engineer this dam, what would you do? Okay, it's an engineering feat, but we have to now consider those kind of things to see if we are making ecological changes, and those ecological changes are going to promote a disease in the longer term. Okay. Next is when we talk about introduction of foreign species into new ecosystems. What do you mean by that?
New species are introduced.
Right. And we are seeing major issues in the Everglades of Florida, where boa constrictors were brought to the US as pets some 20 or 30 years ago, and a couple of them were accidentally released into the Everglades, and now it's a menace. And they have become one of the predominant species, which is not native to the country. Yep. Oops, I need to get this out. Okay, we'll stop here, take a break for about 10 minutes. So Umesh and I will regroup here, and then in 10 minutes, we'll start the case study. Kidding. So I'm very fortunate to have him as a part of this case study to bring in his experience and observations as it relates to the case that we'll be discussing. Okay, so the case that I'm sure you have read these two papers because we will be using quite a few fields on these papers. So Umesh's dilemma. Okay. I've tried to translate it through Google Translation and Amchikodi and other things. I don't know what it means, but I just put it in. So it so happens that, can I reduce this? Upper arrow. Okay, cool. So Umesh Umesh, like many of us of that time period, gets up at 3 a.m. in the morning. For me, when I get up at 3 a.m. in the morning, if I don't have anything, I go to the lab. Whereas Umesh does not have that chance. He gets up and starts looking at his clinical data files. And he's trying to figure out why is he seeing a huge number of cases he's seeing in his clinical practice classified as what we call as megacolon. Okay? So that's where he starts off with. And what does he do? He starts looking at his data charts. And what does he find? He finds that he was amazed to see that from January through December 21, he had a total of 73 cases, whereas for the same period, January through December 22, he had 146 cases of megacolon in dogs, suggestive of megacolon in dogs. Umesh sets up a virtual meeting with his veterinary physicians who work at Happy Tails. Umesh, being a smart veterinarian and of course a graduate of FHPH, he realizes that there is something missing or being overlooked. Okay? What we say, something is biting you at the back of your thought. It says, I don't think that this is right. I don't think so. So he is into this situation. So what do we do? What we will do is we will talk about, to give you a brief history of what we call as megacolon, and then we will engage in a discussion. So I will cover this, and then Umesh will come over and start talking about his aspects. So when we looked at the definition of megacolon, it's a term used to describe a very dilated, flaccid, incompetent colon. This usually occurs secondary to chronic constipation. And the retention of feces, but this may be also a congenital dysfunction in some breeds. Dogs that have waste in the colon are usually experiencing difficulty in passing the stool, resulting in abnormal colon distension that is usually associated with severe constipation. So in other words, megacolon is a functional disorder defined as the dilation of the colon or large intestine that leads to infrequent and difficult passage of feces and constipation. There are congenital forms which are present from birth, and Umesh will relate to his experience. The acquired form is the most form of megacolon, but primarily found in cats and can also occur in dogs. So with that, Umesh takes over from here.
The symptoms associated with the obstipation and megacolon in dogs. Normally, the animals are not comfortable passing the stool, so there is straining. Sometimes the stools are very less in the quantity, sometimes the stools are very hard, sometimes the stools are mucus blood. Automatically, there is too much of a pendulous abdomen because the stool starts accumulating, the animal is in distress, the posture of the animal is slightly changed. These animals tend to lose weight if it's there for a very long time and owner never noticed it. Obviously, the animal is dehydrated because the colonic resorption of water and electrolytes are poorer. Sometimes the animal starts vomiting. Slowly, the appetite starts falling down. It's eating less. You will realize that all these symptoms are one or the other leading to the entire gastrointestinal tract when the animal starts refusing the food, vomiting. Sometimes the stools with the mucus, eventually it results into the severe dehydration. Sometimes the animals are very critical when they are presented because the owner never realized that the dog is not passing the stool. As Bhushan was pointing out that when it is congenital, normally it's congenital in cats, which is very often seen, but sometimes a heavy worm load infestation in a young kittens or puppy literally blocks the intestinal tract. And that is the beginning of the constipation, or later on what we call as an obstipation. So these are the two things which normally a worm load. We normally take care that whenever we deworm a very young kitten who is already passing worms or vomiting, we always give something like a liquid paraffin so that everything can come out. So here we are. Solution. Next. Now, the causes of a constipation and megacolon, genetic predispositions, we already mentioned that if there is any difficulty in parturition, if there is any difficulty in voiding the puppy or kitten out, you will see that there is a little bit of alteration in the pelvic dimensions, and there will be genetic predisposition for that. Tumors. Most of the time, large bowel tumors, which is fairly rare in dogs, rare in cats, but there are other organs which can press a tumor, especially commonly seen in our practice is a non-neutered male dogs where the prostate becomes very big and doesn't allow the voiding of the stools. There are other causes like treatment, what we do. The medical causes are very simple. The dogs on buprenorphine or opioid painkiller, long-term tramadol use as a pain medication slows down the gastrointestinal motility, starts accumulating the stools into the bowels. Sometimes the painful elimination of a stool also occurs with the development of a neoplasia at the anal glands, perianal adenoma associated with the intact male dogs that can result into the painful elimination of stool. Obstruction in intestinal tract, it's one of the most common thing now when the dogs have consumed lots of mangoes and mango seeds. you will notice that this sort of an intestinal obstruction. Sometimes the foreign bodies which are already there but later on passed out without any notice, like a chicken bones or any other foreign body, which can produce a lot of injury to the intestinal tract, slows down the motility and starts accumulating the stools. Spinal injuries. Obviously, everybody is very much aware about the lower motor neurons and the lumbosacral neurology, where the nerves comes out of the L1, L2, L3, and then supports to the colonic passage. Also helps to void the urine, but both if they are affected with the intervertebral disc disease, you will notice that the conduction is not good, the motility is affected, and these animals start showing the habitual constipation over a period of time.
Okay, with that kind of introduction to the concept of megacolon, there's one more aspect that we would like to cover because we will be developing a case definition for megacolon. So that's where you will be start participating in the process. So Umesh, if you can finish this up, and then yep.
A standard normal physical examination, which includes obviously the palpation of an abdomen. Besides that, we do take our few minutes to vital monitoring, or the most important vitals right now are temperature, pulse, respiration. The two new added vitals, which is also a little bit related to this, is the nutritional status of the animal and pain score. Now, both you will realize that the pain will be eventually considered, as well as the nutrition will come a little later. So those two vitals, which are also very important. We obviously, whenever we see the animal in distress, when we see that there is a palpable solid mass into the lower abdomen, we automatically advise an X-ray. Sometimes the X-rays are associated with the plain X-rays or barium studies, depending on how the primary X-ray looks. Dog medical history is absolutely essential because if there is any past conditions which include the gastroenteritis or any surgical interventions or previously removed foreign bodies, we do consider that part. Usually, history detect the underlying issues. Some of the tests which could be diagnostic procedure, which we do for most of the patients, are blood count, urine analysis. Sometimes we do the barium study depending on what the primary X-ray is. We do advise if there is an ultrasonographically changes into the lymph node or other sizes, the biopsies. CT scans for the patients which are likely to undergo second or third time colonectomy, or if they are going for we advise them later on a PEXI, then we do advise the CT scan to have a clear understanding of the surrounding tissue.
The last part, which he will take over and talk about, is treatment. What are some of the treatment options that are available?
Now, as it mentioned very clearly, whenever the obstructions are really chronic and over a period of time, manual removal of the stools, if it is not possible, the option which will be considered will be subtotal colectomy or subtotal colectomy. Now, there are ways and means where we can start treating from the lower order of the disease, how it progresses, simple laxative, enemas, manual removal of stools, under sedation so that there is a relaxation. If nothing works, we do obviously the surgical options. But post that also we have to consider the diet with the high fiber. We have to keep the animals hydrated with the intravenous hydration. We continue. If we do not operate, we continue on to the enemas. After removing the pieces more frequently, we added psyllium, we give laxatives, we kinetics like a cisapride and lactulose as a sugar syrup which softens the stools. Now these are the classic treatments, and we consider these as from the basic manual removal to the surgery. Now this is the options what we have.
Thank you, Umesh. Now, we have 3 questions. Okay? One is to solve Umesh's dilemma. The first question we have is Umesh correct to say that the cases of megacolon has doubled in his practice from 2022 for 2022 as compared to 2021? In 2021, he saw what 73 cases, and in 2022, he saw 146 cases. Wow, jump in 50%. Do you think he's correct? Partly. Anybody else?
It depends upon number, how many number of cases. Yes.
Okay. Okay, good way of looking at it. So what is going to go in the denominator? You have the cases of megacolon, right? But how do you recognize from your clinical practice what becomes the denominator, the number of cases against which you're measuring? So what should be? It's okay. Yeah, good point. Yeah. So you're saying just constipation? So what does go in the numerator? In the numerator, we have constipation, right? But what goes in the denominator? Okay, great. Yes, that's a good one. You can take the total number of cases for that year. Wouldn't it be better to say, let's look at gastroenteritis, gastric disease cases would be a better measure?
What are the symptoms he has described? We can categorize 3 or 4 symptoms. If patient is presenting with that symptom, we can suspect this could be a great chance of megacolon. That we can able to include in
your numerator, not the denominator.
Yeah.
So I'm coming to that. We will actually take on what you're talking about. So in order to say that these are dogs with constipation, sometimes the kind of diagnostic skills that we use may not allow you to accurately classify it as a megacolon. So, and that the whole purpose of today's exercise is to come up with a case definition. So, and I told you in my previous class, what do we need for case definition? Clinical symptoms, history. We require laboratory data, and then we require epidemiologic data, right? So here, what we have described to you is in initial stages, we talked about the aspects of the disease as it relates to the manifestation of the conditions. What do you see? Constipation. More importantly, he used another term, constipation that is recurring and requires manipulation for removal. Okay. So generally in a database, if you start typing, it varies from database to database. If I type in constipation, not all veterinarians in the clinic would have entered the word constipation. So what are we doing? We are losing cases. How do you broaden your search in order to get the right number of numbers, the right number of cases in the numerator, whereas in the denominator, anything that has been associated with the gastroenteric disease goes into the denominator. So with that, let's try and understand what really happened. So the answer is no. So, and I think most of you were almost on there, edging on that particular way of looking at it. So the cases observed are not standardized. They're not standardized for the year. Umesh collated the numbers that represent the number, that's the numerator, the cases as per his definition, what he feels to be defined as a megacolon. He utilized those and started searching for those cases. The numerator must be standardized using an appropriate denominator, or what we call as the population at risk. It can be the total number of cases examined, like you mentioned, or the number of cases identified as gastroenteric-related anomaly being the primary cause. So does not necessarily mean the infection is somewhere else and we are focusing, there's also a gastroenteric involvement. But here we are saying primarily affecting the GI tract, okay? For the years 2021 and 2022. So Umesh goes back to his computer and then says, oh, in 2021, I had 73 cases that fit my definition at a total of 600 gastroenteric cases. It accounts for about 12.1%. Year 2, he sees that increased to 146, but he had 960 cases and it increased to 15.2. Yes, there is an increase, but not the way what we had anticipated as the number of cases have doubled. Okay, so these are some of the things that we need to be very careful when students in your class in epidemiology come and say, the cases have doubled. Oh, no, it did not double. Go and check the denominator, right? Against what are you measuring against? So these are some of the common mistakes that undergraduate and even some graduate students try and make is they tend to forget that this has to be standardized, okay? Umesh, any thoughts? We'll go to the next one, I think. So what are some of the possible reasons that Happy Tail is experiencing an increase in the number of cases? Let's speculate. So we'll go around the room. And then what I'll do is I'll start writing down here your ideas. Okay. Rahul Suryavanshi, let's start with you.
So IT it can be attributed to some genetic reasons.
Okay.
And it also,
Okay, give me one or two, not many, because I've got a lot of people genetic. Okay. Oops. Take a pen. You want me to get a pen? Okay.
she can assist.
Okay. All yours. Cool. Okay, so you say it is genetic, right? Guys, okay.
I still love it. Okay, let's be do.
Something wrong with my finger. Genetics. Okay. What have you to say? These are some of the infection. Okay.
Where the infection?
Yeah. Okay. How about you? Same thing, or you share? Infection? Age? Yeah. It's there in the paper. It's there in the paper. Which one? Diet. Diet. Yes. Anybody else? Foreign material, ingestion of foreign material, obstruction. Yeah. What's it? Umesh, exercise.
Obesity is a correct word. Then the exercise or lack of exercise can cause an obesity. So should I go to obesity?
Obesity. Yeah. Are you okay with it? I'm asking you. You mentioned exercise. I wanted to be sure. I don't want to exclude you. We will write exercise. Okay, great. Excellent. Anything else? Warm load?
In young puppies, we may get a little bit of a obstipating chronic form of.
Okay. Tumors? What else?
These are the basic principles.
Yeah, but
Everything is gone.
First to release actually maybe suppress develop expressions. Okay. And next year, many more patients are coming to you.
solve their problem.
It's a great way of looking at it. Man, oh man. And I'm surprised, you may be right. Yeah. Yeah, you may be right. One second. I don't. 6 and yeah.
Then intervention, medication.
Okay, intervention of him. Yep. What else? Okay.
Now, the owner had become more
Diagnostic.
Okay.
Would have been changed.
That's right. That's right. And,
So where do we
and
start?
also the
Genetics.
cases were not all examined by Umesh, but by his people in practice. Okay. So there is going to be a variation in how you react from veterinarian to veterinarian.
Like modification in case definition.
Case definitions. So we're coming to develop a case definition. Don't go away. We are using all the information. Water intake. Yep, we can do. We can put it in the diet combination. Maybe, but I didn't read about that. I didn't read.
Okay.
There's definitely a breed association and diet.
Better diagnostics, no? What's the-
Better diagnostics. Yeah.
Medication, antibiotics, steroids.
Medicine.
Breed. Okay, Umesh, I think we got pretty good setup here.
All these dogs are on the same diet or different diet.
We're not doing a controlled experiment. These were dogs that were coming to his clinic. So, okay. So, Umesh and I got together, had a couple of beers, and then we came up with a list of things that we think could have played. Okay. Why? Because they may function as determinants, as the determinants for the outcome of a megacolon. So what could it be? One which would highly suspect people who do epidemiology day in and day out. The first thing they ask is, how good is the case definition? Because when you start searching databases, you may miss cases because you have not properly coded them or you have not properly written the reports. So one of the possibilities is a weak case definition. And Umesh opened up a new clinic, and somebody mentioned the number of cases increased in 2022. So perhaps the increase could have come from that additional clinic. Transition from COVID to post-COVID. We do see a significant influence in the number of cases that come to the clinic, okay? And the type of cases that come to the clinic. Umesh, jump in anytime.
And obviously the most important, owner vigilance post clinic is definitely increased. So we do understand that the owner take more interest in their pets. Probably there is better diagnostic.
Why didn't you go ahead? Yeah.
Diet related, that is one part which is nowadays debated a lot, whether dry extruded food can create more amount of hardening of the stool. But a good diet is fairly balanced diet as far as the fiber is. So we just leave the diet outside for the time being. People do ask me about the raw meat, cold diet available right now. Will it cause this sort of a may or may not be? But still, in general, the diet is still needed. Age related, we discussed about it in the young puppies, kitten blockage associated with various reasons. Breed predilections, mostly the large breed dogs and the dogs with the obesity. Somebody mentioned about the exercise was a fantastic point. We need to include that. Cases emerging from zip codes. Now, unfortunately, in the clinical settings, there is a possibility of this sort of a demographic representation when you have a uniform software which tells you the client zip codes, and then you can separate it out. Better diagnostics, obviously the radiology and the contrast radiology or X-rays helps these sort of a cases. Ultrasound, yes, ultrasound do help in figuring out what is the not only the status of the intestine but the lymph node associated, including the prostate, any other surrounding tissue causing any changes, detection of a tumor, detection of a GI tumors. Ultrasound can work fantastically. Routine blood work, and yes, obviously these animals are dehydrated, they have electrolyte imbalance, so strongly advise routine blood work. Better understanding, yes, over a period of time, better understanding of the disease as it starts coming. The veterinarians, the only thing what I would like to point it out is, we go back to the first point. Now this definition is for me and my staff has to be uniform, whatever. Otherwise, my definition is different, your definition and third person. So we require that definition. And mostly we look into that. That is the strongest point, which was lacking in the clinic. Obesity, diabetic, and other medication. Definitely, these are the points which we have discussed. Obesity, exercise related, diabetic. Again, that's a point which is metabolic imbalance. Medication, we do talk about a medication constantly. Any of these painkillers will result into the lowering of the mortality. So, next.
Wonderful. Thank you, Umesh. Now, we will put the ideas into, got to go to the next slide.
This is not
How do I go to the, oh.
Go on.
Perfect. So here, the next question is, can you help Umesh with developing a case definition for megacolon? Okay. So in order to do the process, what we typically tend to do is we create a line listing. So in the process, we collect the base information, which we require in terms of, what do we require in terms of? Person, place, time. So that's what we are saying. Okay, keep that in mind. Yes. Year, age, breed, sex, and zip code. This is what is absolutely essential in order to compute your epidemiologic model. Next is clinical signs and history. So if you really look how we develop this clinical signs and history, here we take into the veterinarian's diagnosis. Very important. He just doesn't come and sign off with give medicines. He has his diagnosis, right? Then he may have performed some blood work. So what are some of the inflammation markers he's looking at? And any notes from him. So this is what we typically compile from a given database, either from one clinic or multiple clinics even better. But this is largely done in order to come up with a working case definition. Okay, a working case definition. Something very important that the veterinarian has to know is the diagnosis should be if he or she classifies it as a colonic or megacolon, there has to be constipation with or without gas, and an enlarged colon, and a previous history of being treated for constipation. So the definition becomes fairly much tighter in order to pick the cases off from the thing. Have I missed anything? Okay. So Umesh provides us with a lot of the information. Now you know a lot more about megacolon. I'm really interested in developing a case definition. One is demographic. Would you agree with the age? Should we go for a lower age? Should we go for a higher age?
I think the 7-year plus is a decent age, because as the age advances, the gastrointestinal motility will start getting lower. Possibility of the other diseases, which could be osteoarthritis, hind legs, it will be probably intact male dog. You have a prostatomegaly at this age. The spine gets a little weak, spine spur starts accumulating, or intervertebral this disease starts progressing rapidly.
So the next is male or female. Any experience? Do we see male more?
I think the male shows because of a very dominant prostate in the pelvic cavity, because pelvic outlet is either urinary outlet prostate, and then there is a rectum. So if the prostatic enlargement is most commonly seen in intact male dogs, so automatically the males are more prone for it. But unless there is some neck tumors or anything which is a pelvic tumor, if there is any intrapelvic growth, then probably the females are equally affected.
Okay. Address and zip code. Let's follow up on the next is clinical signs, because the clinical signs have to be fairly tight in order to prevent other ways of interpreting the process. For example, history of constipation, okay, with or without gas, and there's a history of treatment for constipation that becomes a good tagline to do the searches. One, what's the veterinarian's diagnosis? It's called megacolon with constipation, with without gas, and enlarged colon. Previously treated for constipation. And in terms of diagnostics, blood work, we look for tissue damage markers, WC differentials, C-reactive proteins, ESR. ESR is considered to be a very effective marker, especially when it comes to megacolon. Plasma viscosity is also taken into consideration. And when you have read those papers, one of the review papers has come out with kind of a sense that ultrasound and X-rays may not allow you to truly characterize and say this is a megacolon just by an imaging process. Okay. Microbiology, anaerobic and aerobic cultures preferable, especially when you're looking at Clostridium group of organisms and Bacteroides. Why? Why do we focus on these? And what else? Yes, that's a good way of looking at what else. Something more with these two organisms. Yes, Bacillus fragilis can produce toxins, so does doing a microbiological analysis wouldn't be harmful. Okay. Yes.
How much is ESR sensitivity?
The erythrolytic sedimentation rate, which is being mentioned here, is goes with the previous history of inflammation. What we first put it as a gastroenteritis, only for that.
No. I think I'm prone to accident today. Okay, so now that you're armed with all of the answers, let's move on to the process. Now, your task as a group is to identify the 4 clinical signs that would fit the definition of a megacolon. What are the 3 laboratory tests that you will do? And then we will then talk about how to utilize this information to classify the case. Okay? So we will give you 5 minutes. You can work around. I need 4 clinical signs based on what we talked earlier. If I had a note, I would usually rank them, go around the table and it said, how many people said constipation? How many said this? How many said that? Then I would rank order them and then place them accordingly, okay? So give me 4 clinical signs in what you think, if you're seeing a case of a megacolon that you would utilize to include as clinical signs. Yeah, just make a note, and then I will go around the room. Yeah. And what are the 3 laboratory confirmation tests that you will use? If it was COVID, it would be very simple. It's a PCR test or an antigen test. Whereas here, we don't have anything that will help you make that clear-cut decision. So what is it that narrows down the process?
The newer probably diagnostic methods may include some of the genetic testing. So if the genes are very prone for megacolon, but that's a future. It's not yet.
So are we ready or should we wait for a few more minutes? Okay.
We discussed almost 8 or 10. Out of that, we have to see 4 most commonly seen in every single megacolon definition.
Good timing is good for you. Okay, this is the last one.
So which is the first now?
Okay, give me a minute. Let me type it. So your answers are
The constipation means hard stools, training for stools, stools with a smaller quantity with mucus with blood. So everything comes into constipation. Okay. So the next.
what's the next one? What would be your second?
Pain abdomen.
There may be other cases that may also have pain.
No.
Anorexia. It's a common kind. Second can be distension abdomen with palpable.
Palpable abdominal mass.
And maybe X-ray.
Okay, that's
Okay. What's the third one?
So not eating and dehydration will be one of the most common sign for any of these conditions. So they may not be so specific.
So weight loss,
Vomition.
Vomition is yes, and then all the advanced metacolon cases or obstructional cases will cause vomition. And sometimes the vomit may be having a fecal smell. So vomit.
Okay. Last one.
The last one, somebody said about just now.
Weight loss.
So the thing what I will put it is, if the patient is dehydration, if the patient has got a chronic constipation, repeated constipation, his intake is less because that's what we have mentioned. So potassium will be always low and that will further cause the constipation. So we need to find it out hydration status and electrolytes. So this will be covered here, but related to that point is anybody?
Avoiding the volume of feces.
But that will be the covered and constipation. So inappetit,
What's it?
not eating.
anorexia.
Anything else?
Normal diet.
Normal?
Normal diet.
No. We are talking about clinical signs.
Yeah. You're looking for one more clinical sign.
Progressive anorexia.
Progressive anorexia.
Pain in abdomen. Diet.
You say that abnormal gait and posture. Posture that is abnormal gait and posture.
During the defecation, there is only posture, there is nothing is out, coming out.
Okay.
But an abnormal posture is the dog, and dog walks into the clinic normally, so I won't be able to say that there is an abnormal posture.
I think we had a good discussion. We are struggling to find the fourth clinical sign. We are trying to push ourselves to find a fourth one. We are comfortable with three. Well, it can be the dog. You must have taken the dog for a run for 5 miles, and the thing is weak the next day. So for the purpose of this class, let us go with 3 clinical signs. Okay. So these have to be presented: constipation, palpable mass, vomition, degrees of vomition, how you would classify. If at least these conditions are present, then at least it says we are narrowing based on clinical criteria. What about laboratory confirmation? But the paper said X-ray is useless. How are you trying to push yourself and say get an X-ray?
But the paper have shown some X-rays, they were so typical.
Yes, exactly.
So typical that nobody will miss it. So the X-ray will still keep the X-ray.
Okay. Let's good choice.
That's an easy tool available in a clinical setting. So let's put it in X-ray.
Sure. So any one imaging. So either you go with sonography or radiography, and you can't charge a bill with a sonography and an X-ray at the same time. You will get slapped from both places. So
we call it an imaging. So
let's put
image.
okay. Let's put image. Okay, great. What's next?
Microbiology of pieces.
I wouldn't go there.
That long time for a patient is not there. So the second will blood parameters.
Blood
Blood test. Let's check the blood and electrolytes. Each. Okay, the last one. Okay.
You want something?
Blood will have an ES. So that's fine. Sir.
Yeah, so, yeah.
Can we add gastric emptying study here in laboratory investigation?
In a lab investigation.
See, when we are looking at a clinical definition, and the whole idea of giving this is that you leave the megacolon, you can put a paroviral enteritis, you can put a rabies, you can standardize your own case study, which is uniform across the clinics, your clinic at least. So this is the whole idea. So instead of going into much detail, what is the things available at your own clinic or at the polyclinic or wherever you are working, what is easily available, we'll select it.
Okay. So what happens? This gives an additional level of confidence to the practicing veterinarian as to how to classify the case. So if we say if it is a confirmed case, it will have at least 3 of these clinical signs. It will have laboratory information will confirm it to be a positive. And then the physician's diagnosis is very important. The physician is identified as megacolon. When we say probable case, and I would say here at least 3 of the 4, I would say at least 2 of the 3 symptoms. The laboratory test is still pending, megacolon, so it's a probable case. Next is possible case, when acute onset with at least 1 or 2 symptoms would be there. Again, lab testing performed, and when we say suspect, no clinical signs, but unexplained blood work or microbiology report, depending on the case, not performed, and then the physician has said it's a megacolon. When we say it's not a case, failure to fulfill the criteria for a confirmed, probable, possible, or suspect case, laboratory test negative or not performed, and the veterinarian says there is no diagnosis. So in the process, when you start utilizing this as a template, as a fresh veterinarian who comes to your clinic and starts practicing for you, says, how do you identify megacolon? What are some of the things that you need to be looking for? And how do you grade it? Because based on where it is graded, the treatment will also change, right? So those are some of the things that you need to do. Is now, in terms of epidemiology, this becomes very important, especially if you're doing surveillance. You're going out on the field and you're trying to collect data. So these set of case definitions become extremely important so that we are able to collect the right number of, accurately identify individuals and animals with the disease and without the disease. So with that, we will stop here. And somebody else. Okay. And we'll continue after lunch. Okay. And a round of applause to Umesh. Thank you so much. Yeah, go ahead, Jordan. We will meet at 2 o'clock. If you want to, you can.
तिकडे घेऊन जा. हे दोन्ही हे जवळ but I request online participants, please, if you have any queries are there, doubts are there, you can ask to sir about whatever or you can put it in the chat box. Okay, now I invite.
Okay, so
Anu, you can read the chat box if one question is there. I think. Okay.
I responded to it.
Yes.
Case fatality is same as virulence. The way we calculate is we calculate virulence, we are calculating case fatality. Yeah. So let's start off the afternoon session with data presentation. So one would ask, why are you telling us about data presentation? Because ultimately, I would like you to focus on histograms, which is the very starting point when we initiate a disease outbreak investigation. So you need to create histograms. In order to understand histograms, you need to understand what do we mean by variables? How do you classify these variables? And how do you present these variables in order to make meaning out of it? So the first 10, 15 slides may be a bit kind of repetition for a third or a fourth grade student, but this is something that I'm trying to revisit and impress upon you. These are some of the things where we make common mistakes as to how to categorize our variables. Okay. So with this, let's start off with data presentation. So in this lecture, we'll talk about the different ways how we can present frequencies. And the word frequency was on the third slide in the first day of the presentation. How do we describe, how do you present frequencies? Okay. Next is, how do we understand the different type of thematic maps? Nowadays, maps are absolutely essential in whatever we do. And there are some phenomenal softwares that can generate geospatial mapping data, can allow you to plot information the way you want. So we'll talk about different type of thematic maps. So once you have a better understanding on the frequency, displaying the frequency based on the type of variable and the different thematic maps, then we'll jump in and talk ad nauseum about what we call as epidemic curves. Any questions? Okay. So when we say the word variable, okay, it's an attribute, phenomenon, or event that can have different values. Again, I've taken it out from the dictionary of epidemiology. So a feature or a factor that is liable to vary or change. So that also we need to be appreciative of when we talk about a variable. Okay. And what are some of the examples of the variables that we use quite extensively in epidemiology? Age, ethnicity, nationality, animal breed, sex, disease status, and exposure. So these are some of the common variables that we include. Now, how do we look into the different types of variables? So the way we look at variables is we can group them into two broad categories: qualitative variables and quantitative variables, or quantitative measurement. Okay? So when we talk about qualitative variables, they can be two forms. One is nominal, that is which is not ordered. Another one which is ordered. For example, nationality. For example, if you're talking about severity of illness, we can say severe, mild, moderate, and we can rank it in the process. So that's how we take qualitative data. In other words, these are non-numerical data that we are able to categorize. If they are nominal, not ordered, once that is, another one is the ordered one, which we call as ordinal. In terms of quantitative measurements, there are two types of data sets they use. Again, these are numbers. They can be discrete or total whole integers, what we call as number of vaccinations, right? I still would like to see if somebody says I got 1.5 vaccines. Less likely, it's vaccination, it's the number of vaccinations. Continuous variable. So when we talk about continuous variable height, or it can be weight, okay? Any of the biological measurements. So using that, let's try and understand a little bit more in terms of qualitative and quantitative variables. In terms of qualitative and quantitative. For example, when we talk about qualitative and we say it's a nominal variable, and I gave you the example of nationality, I've listed down the nationality, not in any specific order, but as the individual has been identified. Now, when we talk about ordinal, it is characterizing the data based on whether it's mild, moderate, severe, as a kind of a way. But utilizing this, we can rank the number of observations that are severe, mild, or moderate. Discrete is self-explanatory, and so also is the continuous variables. Okay, and these become very essential, especially when we plug in the information when we do disease modeling at some point in time by the end of this course. Oh, okay, here it is. So how do we display one single variable? When displaying the number of occurrences, whether it is qualitative or quantitative, they can be expressed in several different ways. For example, if the variable is qualitative variable, the best way to present the data is either through a bar graph or a table. Another is if it is a quantitative variable, we use histograms. Again, I'm referring specifically when we talk about epidemiology. We use histograms or present the information in the form of a table. And many a times we see graduate students come up with fancy charts and figures and tables, and all that you need is a red pen and cross it up and say, this is what I don't want. I want the table to talk to me. That's the first thing you would say. The table, when you look at the table, it should talk to you. So unless and until you do that, I think you're not doing justice for yourself. You're trying to impress me. That's great, I like it. But that's not going to help you in your career if you really look at it at that point, okay? So next is we'll talk about tables, bar graphs, and histograms. So when we talk about tables, these are nothing else but frequencies of qualitative data, especially a single variable that is best presented in the form of a table. Example, and come to an example later on. The advantage of tables over graphs is that actual values are presented. And some people are more comfortable with figures. Some people are more comfortable with numbers. So typically what we do is looking at the audience, or looking at the type of group that we are presenting, we can make a choice what works best at that point in time. If I'm doing a poster, I would definitely like to have a graph, right? But if I'm presenting in a classroom, I would like to have a bar chart, or in a paper, because it's going to appear much better in terms of understanding it. Sometimes tables communicate information better than graphs, even with complex or multivariate data that is presented. So that's one of the things we always would like to impress upon is keep it simple, but keep it focused so that it conveys the meaning that you want to, that you expect the audience to gain from it. So what are some of the characteristics of the good table? The first is descriptive title. Many times when you see a draft of a thesis come on your table, there's nothing else. There's no descriptive title. There are no what we call as demarcations as to say in terms of units of measuring. What is it this table related to? So usually we need to have a very descriptive table that describes the material that you're presenting. Okay, it should be not vague. It should not have adjectives. It should not have superlatives in it. It should be very precise and convey the meaning that is given there. Now, the data is presented in rows and columns. Show the totals for each rows and columns if it is possible. Very important. and then explain the abbreviations in the footnote. And now this is what I would call a classic table in which there is a nice title which represents the presence of primary and secondary syphilis by age and sex in the United States in 1989. So here, what have we done? We have taken the age, broken down into the age brackets based on the recommendations of the census, so that if somebody wants to compare our data, they can use the same age groups for comparison, okay? Number of males, females, and totals, and then we express them in the number of, total number of observations for each of those columns. Now, here is another way we can look at it is by age group and the numbers, just by itself as a single process. So let's talk about a bar graph. What are some of the characteristics of a good bar graph? The bar of a frequency of a qualitative variable. Each variable is represented by a bar. The length of the bar is proportional to the number of events. And more importantly, when you graph it, the bars shouldn't touch each other. So here is an example. This is an example where when there was an outbreak of flu in Europe in 2005, just around the same time, they had released a drug called as Tamiflu. Do you people recollect the word Tamiflu? That is oseltamivir. Okay, that was available as a treatment for flu. Yeah. So it so happens what this Eurosurveillance study looked at is, based on the number of prescriptions for 1,000 people, which country had the maximum number of prescriptions written, okay? So here we see that Denmark had the least per 1,000, whereas Germany had the highest level, close to 5 and above number of prescriptions written per 1,000 people in that country, okay? So on the x-axis, we have the country. On the y-axis represents the number of people per 1,000 that received the prescriptions. Okay. Here's another way of looking at it when we talk about the percent of infants who by the 7th month of age had received vaccination by dose and type in Minnesota. Now here we have categorized the dose based on color, and the 3 different vaccine types have been presented in each of those categories, and what percentage of the population took those vaccines the first time, the second time, and the third time, okay? So here you can see it clearly lays out and says, first vaccine, very high rates of coverage. Second vaccine, little less. The third one falls significantly short. And this is just not with diphtheria or Haemophilus influenza B or other types of infections, but this is consistently seen. Even if you look at COVID data, everybody went and got their first shot. They jumped on each other and said, give me a vaccine. But when the second one was supposed to be taken, the enthusiasm was low. And when they said, we have a new one for a variant for BA.5, we are not interested. So a few of us like me went and stood in the line and took it, but the numbers tend to decline. This is a natural phenomenon that typically happens with vaccines. Right? And what happens as a result of that? This is a significant significant importance to public health. Yes, level of immunity. What type of immunity?
Herd immunity.
Herd immunity. So the herd immunity, we don't tend to achieve the expected number of vaccinations that we would like to have if we don't complete the 3 vaccines. In case of childhood, these are all childhood vaccines, right? So this has to be encouraged to the nurse in the school, to the mothers, to the pediatricians that doing all 3 vaccines at the prescribed time is highly recommended to give a full level of protection to not only the child, but the children around them. Yeah? So here's another way of expressing, which we very frequently use, is the rates of malaria by region A, by species and year. So we're looking at malaria and as compared to falciparum. And what are we observing? We are observing that the number of cases of falciparum from 2005, 2007 to 2009, as described in the x-axis in terms of years, is increasing over a period of time, especially when we are computing on the y-axis the rates per 100,000 people. So this is kind of an impression that one gives and looks at it and says, yes, I do see an increase in the number of cases of falciparum. Will you believe it? Or will you not believe it? No? Why? Why? Tell me why. Let's have some fun. Why? I would believe it. Why don't you believe it? Data is great. I would believe it because they are expressing at a rate per 1,000 people. Okay? If that rate wasn't measured and just percentages were expressed, I would be a little careful in trying to interpret the data. So they have already standardized the information and then presenting it to you, right? So that's very critical when such kinds of data are presented, because you can miscrew the information and present it in a different way. Okay? Histograms. Now the fun starts. So when we talk about histograms, histograms are what we call as the bread and butter of doing epidemiologic surveillance and outbreak investigations. So let's spend a little bit of time and talk about what are some of the characteristics that we should see in a histogram. So histogram is nothing else but a graphic distribution of the frequency distribution of a quantitative variable. Okay? This is helpful for summarizing statistical property of the data set, including the shape and the frequency of the curve, the shape and the frequency, how the frequency of these number of observations come over a period of time, and then the level of symmetry. Is this symmetrical? Is it skewed to one side? Because that tells us a different set of story. Each of the column is proportional to the number of observations, and the interval in the interval columns are adjoining. Okay. Epidemic curves are histograms. Okay. Take home message: if you generate a histogram, invariably you're working towards an epidemic curve. So they are the fundamental tools in an outbreak investigation. So with that, we'll talk about a few of the different type of mapping systems that have been widely used. One is called as the scatter plot.
The basic difference in bar graph and histogram as per the data analysis of presentation of its inference is concerned.
Which, so you want me to go back to the previous slide? Here, are you talking about this?
This slide earlier.
Okay, let's go back to the bar graph. Let me go from here. You're talking about this? Okay, in terms of bar graph, the way we present it is, what is missing? Why do we call it as a bar graph? And why do we call it as a histogram? Time is essential, okay? And where do we put the axis of the time? In an histogram, it's on the x-axis. And the number of observations are on the y-axis, okay? That is one of the basic things in a histogram is, what are we trying to do with a histogram? Over a period of time, how many cases have emerged? Okay, so in the x-axis is time, in the y-axis is the number of cases. That's typically we don't tend to do with bar graphs, because bar graphs generally we tend to use qualitative data. Here, we are using quantitative data. Does that answer your question? Are you still confused?
No, I'm interested to extract the inference of data on the basis of bar graph and histogram.
I give you that information. Histogram is quantitative. when we go back and talk about a bar graph, how many number of children took vaccines for different types and at what frequency? There we are not measuring the time intervals. And on the y-axis, we are taking the number of observations in relation to taking all 3 vaccines. Okay? Are you able to get me? The x-axis in terms of an epidemic curve will exclusively show the time in a linear fashion, not in a circular fashion. So you start on January 1st, you continue forward ahead, okay? So that's the way we put it. On the y-axis is the number of observations you see for that given date. Does that help? Yeah.
We usually see coronavirus.
Right, right, right.
We can create
Mhm.
age.
Right.
What intervals, how to decide the mean? We usually do is we analyze in Excel.
Okay.
Power computer only to.
So the 3 of us can talk later. Let's talk a little later because we are diverting away from my train of thought with the next set of slides. Yeah, definitely we can talk about histograms, application for clinical data. In application for clinical data, the way we present is if you have collected hemoglobin concentrations of 50 different dogs, okay, what do? You categorize based them on range and age. So those are the 2 things that you can do, and which axis you would like to choose. Usually the range is put on the y-axis, and the different breeds or the age of the dog is put on the x-axis. And that also you can create a range, 1 year to 5 years to 7 different ranges. Hemoglobin is greater than 13 plus, is less than 7, or however you would like to categorize. Yeah. Okay, so I think I'll go here. This is okay. This is where we left. Yep. So when we do scatter plots, it's a type of a graph which shows a relationship. Is there anything I can help you? So it's nothing else but a relationship between 2 variables. Okay, variable A or variable B or variable X or variable Y, however we would like to put it. The measurement of the 2 variables are made on an individual entity, one single individual or entity, or a unit of study where patterns can be assessed visually. So here, what have we done? On the x-axis, we have the age from 10 years to 60 years. On the y-axis is the exposure to heavy metals. Okay, or if you take a sample from these individuals, what do we see? With increasing in age, we find an increase in the heavy metal concentration. So that's the impression that one usually derives from. Now, usually these kinds of data, when we generate, are used for generating hypotheses. There is no way of proving that all people above the age of 50 will have close to 20 picograms of a heavy metal. Okay? It is a suggestion or a hypothesis that you will derive. If I'm going to be doing a study, should I focus on this group in order to understand what are some of the dynamics and changes, or should I be focusing on this group based on the type of metal that you're working? If I'm talking about lead, I would focus more on young children, right? So how do you utilize this data in terms of generating a hypothesis, especially looking for children under the age of 10, in terms of interpreting the lead levels in their blood? So then that allows you to come up with the right kind of hypothesis to do the next set of investigations. So thematic maps. So thematic map is a map that is shows the geographic distribution of one or more variables, rates of disease, and location of cases are common uses of thematic maps in epidemiology. And voila, GIS, Information Systems Technology, has made generating thematic maps much faster and easier than ever before. You just take a look at your Google map on your phone. I mean, you can drop so many different pins on it and then create a map for yourself, okay? So the technologies have far surpassed what were our expectations 10 years ago. So even today, I would say some of these technologies are so user-friendly. You don't need to really spend an enormous amount of time learning them. So here is a rendition of what we call as a thematic map that was drawn on a bone some 13,000 years ago on a mammoth bone, kind of describing the dwelling near a riverside. So when we talk about thematic maps, there are three types that we typically tend to use in epidemiology. The first is called as the spot map or the dot map. Next is chloropeth. Another is isorhythmic. So dot map, I've already exposed this to you when we talked about the history of epidemiology, okay? This is where John Snow, yes, this is where John Snow kind of went house to house, knocking on the door and say, tell me how many people are sick, how many number of people live in your house, okay? And it's often used to show graphical location, geographical location of individual rather than the rates. In other words, we like to see if there's a clustering of events taking place utilizing the dot map. So it kind of draws us towards an attention and say, yes, there is clustering effect and we need to address it. Okay. Next is a chloropeth map. This kind of maps are useful, but they are more used by people who are in social sciences. For example, I'd like to say the level of education. How many children have completed undergraduate education? How many have completed college? How many have just finished the 12th grade? So we can use this as a way of grading the social distributions in a given map, or you can take age and then distribute it. So here in this map, they utilized the chloropeth map to look at the cumulative cases of cholera in Zimbabwe for several different districts here on 18th of August from 2008 to January 11, 2008. So it clearly shows the indication of the intensity of the color represents higher number of cases. So at one glance, this should tell you, oh yes, there are parts of Zimbabwe that have very high rates of cholera as compared to others. And that draws the question, why? Okay, so your hypothesis is cholera is not equally distributed in Zimbabwe. It is there in certain places. The question is, why does this happen? So you then utilize that as a hypothesis to go and prove it, right? Okay, this is another one, what we call as the isorhythmic map. Isorhythmic map usually is used to look at how disease spreads over time. So that's the most useful value of an isorhythmic map. So we use only continuous variables in developing an isorhythmic map, and the points with the same value are connected by a line. Examples, the variable is the event that occurs as it relates to place, time, disease, and event. So let me explain this a little bit more in detail here. So this was the time frame of 1341, where they started seeing cases of plague in Europe. Following a year later, or year or two later, the disease moved northward, okay? And it is shown depicted by another color range. Now, when we look at the countries further up, it took a little while for it to reach, but even with that, there were zones with a given area where the disease was never recorded, historically recorded, although they may have occurred, but historically they were not recorded. So here we can say a cluster of events took place in the lower part of Europe, followed by the migration of the disease northward over time. Okay? From 1341 to 1347, you can see the movement of the disease in one direction. Okay. So what's an epidemic curve? An epidemic curve gives a graphical display of the number of incident cases in an outbreak plotted over time. The word here is time. Time goes into the x-axis. Okay? The form of the resulting distribution of the cases can be used to propose the hypothesis of the nature of the disease, the mode of transmission. Epidemic curve can provide information on the pattern of spread, magnitude, what is the breadth and depth of the disease in a given geographical area, what are some of the outliers, time trends, exposures, and we can also use it to determine the incubation period. Okay? So this has a lot of stories behind stories in one single picture. And let's try and understand this a little bit more and better. So when we look at it, there are two types of major curves that we use in epidemiology. One is called as the common source type of epidemic curves, and the other one is person-to-person epidemic curves. So let me put up these curves, and what we will do is we'll talk about these curves a little bit more in detail. Want a break? Are you good to go? Okay. Okay, so let me backtrack, if I can backtrack. So keep in mind, we will be talking about two very important types of curves, the common source and person-to-person. And each of these different graphs that are histograms that I presented for you, I'll be talking about them, okay? So the first one is the common source. So what do we mean by common source? A common source outbreak is one in which people are exposed intermittently, continuously to a harmful source, for example, bad batch of food, industrial pollution of contaminated water supply. And by controlling these, we can stop the outbreak. Okay? And what are the three types of common source epidemics? Point source, continuous source, and intermediate. So let's look at the point source. So point source without propagation. What do we mean by with no propagation? All cases appear to occur within one single incubation period. Once you plot the data, you're able to go to the maximum period where you saw the maximum number of cases, trace back in time, and then drop down. And then drop down a point in time to tell us where is it likely the infection started coming into the population. Okay? So that's what helps us. For example, if you know it's an E. coli outbreak taking place through water, so we know we can go back in time. There was a big tank of water that had water in it for a long time that was released to the city. And as a result of the release of the city, we started seeing cases. So once the source of the water was stopped, the number of cases disappeared. So we can go back in time and say, oh, when did they release the water? So those are some of the things these epidemic curves helps us to do. So in other words, all cases appear to occur in one incubation period, suggesting that cases do not arise from person-to-person spread. There's no person involved. The fact that the outbreak was of short duration suggests it was a single, brief, hence point exposure that did not persist over time. What are some of the examples? Embarrassing diarrhea saga following a neighbor's barbecue. He calls and says, I've made barbecue, join me. You and your neighbors go and have a good time. And then 3 days later, he says, uh-oh, something is not right. Okay. This has happened to all of us. Not blaming my neighbor, but probably I've done it to my neighbors too. So
Barbecue of
barbecue of raccoon. Well said. So this is how we can relate these images to events such as a barbecue section. Another is respiratory illness in workers following a breakdown of the fume hood. So if the fume hood is not working, you have certain toxic elements or gases that are circulating, and perhaps as a result, you start seeing the number of cases rise. But when you address the fume hood, they tend to disappear. Okay, next one, continuous source outbreak. The exposure continues over a longer time, or that is contaminated water supply that does not get fixed. So the outbreak persists for a longer time. The relative abrupt beginning of the outbreak suggests that many people are exposed simultaneously. At one given time, a large group of individuals were exposed, rather than it was spreading from person to person. Okay? The fact that no cases rise beyond one incubation period following the termination of the exposure supports this conclusion. Okay? So again, incubation period also plays a significant way as to interpret. So what are these two cases up here? Can somebody draw some inferences? What's happening?
Meat market.
There's a meat market, and what is the other person doing? Shorting shrimps, right? Exposure, yeah. So here, you can see they're all wearing gloves and they're doing a good job. Not here. Let's assume this individual, only in theory, or this individual is infected with hepatitis A. Okay. What are we doing? We are going bang, 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 bang. Cases start coming up. And where do you trace it back? You trace it back to the individual. So these are some of the things that epidemiologists generally tend to look. Oh, we are seeing these in these patients. They ate the meat from these particular stores or shop. So let's go back and look at the source of the material if we can do anything. Okay, so what do we do? What do you do in terms of intervention?
Compulsory to wear mask and screening of the people.
Vaccination. Okay, and you remove people with high risk and give them other allocated jobs, especially in terms of training and in terms of food safety. Although they have been certified, it is better to move them away to another place where they are less likely to contaminate the process. So those are some of the things we typically tend to recommend when it comes to point source infections. Now this is intermittent. I've got a very nice story to tell you about it. Intermittent outbreaks. The curve suggests that the common source is not well controlled. So outbreaks recur. Depending on the time frame, it could be seasonal, weather related, or perhaps due to a common source such as industrial contaminant being emitted at intervals. So while I was doing my master's in public health at University of Tennessee in Knoxville, I did my residency in Oak Ridge National Labs. And Oak Ridge National Labs was known to work more so with chronic diseases. And they were a bit concerned about this particular river, which is called as the Pigeon River, that flows close to Knoxville, Tennessee. And the reason they were concerned was they would see clusters of cases of cancer occurring in one part of the river as compared to the other. And we started looking into it. In the upstream region of the river was a paper manufacturing plant. So this paper manufacturing plant employed almost everybody from that village. And they were not willing to talk to people what was going on in the paper plant. What would the paper plant do? The paper plant would release the waste. When would they release the waste? Really? Any other time? On Sunday mornings, when the people would go to church, right? So they knew the timing. The timing was right. We can release it. It'll look a little cloudy. It's okay. In 4 days, it'll go away. But what happened? A lot of the toxic material became sediments. And when the farmers built channels to divert the water for their farms, it started contaminating their products, their animals. So therefore, we started seeing higher rates of cancer in those individuals because of the sludge that was there in the river. So we were able to prove it to some extent, but not actually prove it. But we came up with a very solid hypothesis saying that the plant was releasing toxic materials. It was largely PCBs, related compounds, that was being released in the wastewater because that's one of the outcomes. When you manufacture paper, PCBs are one of the side products based on the technology that was being used in the 80s. So when we look at these kind of situations, this is the type of exposures you tend to see. Clusters coming up over a period of time. Okay, let's move on and talk about person to person. So person to person is when the disease spreads via person to person contact, the classic infectious disease pattern. This is what we call as the very first curves that we tend to learn about. Controlling the source is no longer sufficient to control the outbreak. So even if I remove the source, or what we call as an index case, the disease will still continue to perpetuate for a given period of time unless and until proper interventions are put in place. And the types of curve here is point source with an index case and disseminated outbreak with an index case with a propagated spread. So let's look at the first one, point source with an index case. Okay. With an index case with limited spread, a single index case, for example, is a returning traveler. Okay. Infects other people, and cases arise after an incubation period. The outbreak wanes when the infected people no longer transmit the infection to other susceptible people, perhaps because of successful control measures such as isolation or quarantine. This graph suggests that this was achieved rather quickly because it's within one incubation period. This generally tends to happen in parties, small gatherings, where the index case may be a person or maybe a food. Okay? We generally say it is an infected person, more so somebody coming down with a flu-like symptom and then giving it to the rest of the people. Okay? Propagated begins like an infection from an index case, but develops into a full-blown epidemic with secondary cases infecting new people who in turn serve as sources for yet another case. So here, that's what we are seeing. Index case, we see the first group of infections taking place. Following a one incubation period again, the disease is perpetuating over a period of time. Okay? This produces successfully taller peaks, initially separated by one incubation period. This is what I talked about, this one incubation period up here. But the peaks tend to merge into waves with increasing number of each cases by generation. The epidemic continues until the remaining number of susceptible individuals decline or until interventions take place. So this is what we call as the theory of exhaustion. Disease will come in, infect everybody in the population, and move away. Okay? So that's one of the ways we tend to see is where we see the subsequent peaks emerging over a period of time, and all of a sudden there's a die out. So that's when we know that this infectious agent has left the population. Okay. How are you placed? You want me to start with this? 5-minute break? Okay, sure. Well, I didn't get you. Mm-hmm. No, it is not secondary attack. Propagated step is we really look at, in one way of looking at it, yes, it is secondary attack rates. But beyond a certain point in time, we will not be able to measure because we are not taking family units. We are taking the entire population. So it is pretty close, but we need individual sets of observations in order. We can do that too, but when you're looking in a disease running in a population, we don't know which particular group it belongs to, right? Especially in a hospital, they will be running the tabulations for you and it will be coming to you. What you don't really know is person 1 and person 12 are from the same family. That becomes very difficult to determine. Yeah. Associated group. Absolutely. Absolutely. You hit the nail. Yep. Or in other words, coming in contact. So there is an incubation period required. You're infected. He may not even get infected the next day.
Not next day exactly, but after 3 days, 4 days.
Yes. But he may not be a part of the family, right?
Family that is needed.
Or a part of a group. If it is an office, yeah, you can calculate secondary attack. So you can say office or a lab. So let's not fix it to a family. We can make it a workplace. Yep. Yep. Mhm.
Few years, the number of increased in that.
Okay.
Reason behind it, the use of pesticides and insecticides by the farmer. And usually the farmers grow in vegetable specifically, which require more pesticides. Recent 10-50 years study is that for Kolhapur district, Shirala is the Taluka where you can have a more number of cancer.
Oh, okay. And what type of non-Hodgkin's lymphoma? What kind of lymphomas? Yeah, usually when we say exposure to a pesticide, they have signatures. The tumors have certain signatures. For example, exposure to herbicides. Generally, we tend to see non-Hodgkin's lymphoma to be more emergent as compared to the other types. It depends on the type of pesticide.
Before that, they were not involved in such vegetable business when they started in that town. They started using more number of pesticides and all. From that, in last 10 years, since they have analyzed that, which taluka number cases are,
Right.
they found that from that taluka, pretty good number.
Oh, is it? Okay. So it's also one of the things when we look at in terms of pesticide, our approach is application of pesticide has to be done by an individual who is certified to apply it. Yeah, so the person has to have the certification. He will know this is so many number of acreage. These are the type of insects I'm going to be looking at. So this is the more appropriate. This is the dosage. That becomes because that's part of the certification process, right? Yeah.
There are certain insecticides which are given systemic. They are not water and all. Systematically, it runs inside the reactor. That is the one. Second thing, when you take out the dose, then seller, company recommend the final on this one so little. The seller recommend double dose. Farmer use triple dose. Likewise, the same goes on. That's the practice. Again, double.
Enjoy this pesticide-laden vegetable. Really? Wow.
And then the final agitator, if there is go ahead and
Oh my God.
Even animal for liver meal for and okay, one in the tablet, 10 in the tablet or another. They are giving bolus daily for one tablet daily like that. So we might have
Yeah.
can be cancer free running from
Oh, okay. I think I've heard that term. I've heard that term, cancer rate. Yeah, you were saying something?
we use Excel for.
Mhm. Right. Right. Yeah, there are free softwares that we tend to use called as either you can use Epinfo 7 that is downloaded from the CDC. I would highly recommend because when I do training programs in other countries in Africa, I ask them to use Epi 7. But there is an Epi open source, which I will be using in the class. You can use that too. That will help you to determine the sample size, help you to calculate odds ratios, risk ratios, even generate random numbers for you. So we will do all of that in the class. So we will be using Epi open source software in order to compute those numbers. Epinfo is the best. Which one? Epitools is good, but the way I go and look at it is how many of the peer-reviewed publications have used it. So just because I like it, I'm using it. I would like to see if others are also using it and how well they are using it. It's easy. Yeah. So if anyone wants to do PhD, we will actually ask you to do these things by hand. So if I ask you to compute time series, you'll be doing it by hand. You'll be forgetting all the software. So we are not yet there. We are 2 years from now. Okay, should I move on to disease frequency? Okay, so in this part, we will utilize ways to measure the frequencies. How do we measure and how do we interpret these frequencies? Okay? So when we look at measure of disease frequency, the first and the foremost is the basic line is what are we trying to do in this in an epidemiologic setting? Is truly trying to identify who have the disease versus those that do not have the disease. Okay, that's the first thing. Next is what proportion of population are still at risk of getting the disease. So these are the population at risk that is not diseased. What is their risk? Is this risk 5 times higher, 5 times lower, 10 times more? That's what we will estimate as we go along during studying about the disease frequencies. Okay. So many a times in epidemiology, the base thing that we use all the time is rates. But it's we need to know what's ratio and what's a proportion so that we have a better appreciation what we mean by a rate. Because many a times people not use denominators, and if you don't use the right kind of denominators, your data is incorrect and your interpretations are incorrect. So let's try and define rate, ratio, and proportion, and then compare the three one against each other. So when we look at ratio, the question we are asking is, what is the ratio between males and females? Any other numbers? Okay. So what is so very important? We are trying to compare the now ratio of the females to males. So the numerator comprises of females and the males comprise of the denominator. So the way we express, for every one male, there were 2.5 females. Okay. So this is how we express. What is so very something interesting here? The denominator is not related to the numerator. There's no relationship. Okay? So keep that in mind. Many a times people tend to confuse. So this is how we calculate a ratio. Okay? Let's do an example here. A city has 4 million people and it has 500 clinics. Calculate the ratio of the clinics per person. So how do we start? We have 500 divided by 4 million times 10 to the power of n. We'll talk about what do we mean by power of n. So when here, in this case, I've used 10 raised to the power of 4. Okay? That's 10,000 individuals. For every 10,000 individuals, what did we find? There were 1.25 clinics for every 10,000 individuals. Okay? Where, as I mentioned earlier, 10 raised to n can be either 100, 1,000, or 10,000, depending on the size of the population. So this would translate, if I utilize 100, then it would be 0.0125. But it doesn't make any sense if I put this in a newspaper and say there are 0.125 clinics for every 100 people. They say, this guy's stupid, right? So, something that is more understandable, something that is more relatable would be per 10,000. Okay, it's 1.25 per 10,000 and per 100,000. Otherwise, it's 12.25 per 100,000. So the value here, 1.25, can be divided by 10,000 again, and can be expressed as for every one clinic serves 8,000 people. So the interpretation, very important in epidemiology, is interpretation. 1.25 clinics per 100 for 10,000 people, or one clinic for every 8,000 people. Okay? So this is how you convey the meaning when you utilize ratios. Okay? Give it a try. Okay. All set? Okay, let's try and see what's the ratio. 1:2, okay. 2:1, okay. So the ratio is for every one death that occurred in Car, there were 2.8 deaths in Dharavi. Okay. So Dharavi's infant mortality rate, in another way of expressing your idea, is 2.8 times higher than that of cars, infants mortality rate in 2001. So we have covered the places, we have covered the time, and we have covered the people. Okay, so that completes the story that we are trying to tell. Oh, what happened?
Close that.
Close that?
Okay.
Close it? There are 3 participants. They're trying to wait in the lobby.
They will add.
They will add.
Minimize it.
Okay, minimize this one. Okay. Okay. How did it jump? Okay. Okay, cool. Oh, so now let's talk about proportions. Okay. So we talked about ratio. Let's talk about proportion. So what's a proportion? A proportion is a comparison of the part to the whole. Okay. Yep. Yeah, there are 2 quotient numbers. The numerator is included in the denominator. So that becomes a proportion, and the proportion is expressed as a percent. So in the numerator, we have 5 females. In the denominator, we have 5 females and 2 males. And the ratio is the proportion is 0.7 or 70%. Let's go on and talk about rates. This is now where the fun begins. Rates. A rate measures the probability of occurrence of an event in a population. So the probability of the occurrence of an event is measured by rate. It allows comparisons between 2 populations. This is the most serious aspect of a rate. Keep this in mind. When we express a rate, we are comparing the rates as compared to 2 or 3 different populations. So a rate provides means of comparing the occurrence of an event, such as cases of deaths in one population, to similar populations by adjusting for differences in population size, frequency in the numerator, and comparison of the population in the denominator, that is x divided by times k, and expressed as either 1,000, 10,000, or 100,000. So what do we have in the numerator? In the numerator, it includes the number of events, number of cases of gastroenteritis, number of cases. Okay. Okay. So the numerator just comprises of events of a given condition, whereas the denominator. Okay. Can you go back to the previous screen? Oh, cool. Thank you. So the denominator includes the population in which the events are occurring. So if the events are occurring in Mumbai, we utilize the population of Mumbai as the denominator. Okay? So for example, in year 2000, the rates of new hepatitis B cases in Kanpur was 200 cases per 100,000 per year. So again, trying to reinforce person, place, and time. Very important when you do it, because if you don't do it, you're presenting the wrong information. Okay, somebody will say, "Oh, 2000 year is not there. That means it's applicable all during the year, all years." So no, we have to be very specific. Okay. Double click.
Not there.
Then, okay. Uh, so in terms of the type of calculation, so let's compare ratios, proportions, and rates. As I mentioned earlier, ratio is a division of two unrelated numbers, whereas proportion, the division is between two related numbers. The numerator is a subset of the denominator. Okay. Whereas when we talk about rates, again, it's a division of two related numbers. The numerator is a subset of the denominator. The only difference is we bring in a timestamp. We bring in when did it start, when did this end, or what time period are we doing or are we calculating the rates for, okay? So when we look at the frequencies or categorization of disease frequencies, there are two ways of doing it. One is calculating prevalence, another calculating incidence. So what is the difference?
Older new cases insurance and incidence 20 new cases.
Sure. I think we can go home now. Yes, that's right. So you're spot on. So prevalence is defined as the number of existing cases, that is both old and new, of a disease condition in a population at a designated time. Okay. So again, the timestamp has to come in. It is useful for assessing the burden of a disease in a population. And the way we calculate this is looking at the total number of existing cases in a given place at a given time, the number of persons in that place for that year, and then express the prevalence either between 0 and 1 or 0 and 100%. Okay? Good. So this makes my life very easy. In 1999, Himachal Pradesh reported an estimated 253,040 residents over the 20 years of age with diabetes. The Census Bureau estimated that in 1999, Himachal Pradesh population over 20 was about close to 5 million. Perfect. So in 1999, the prevalence of diabetes in Himachal Pradesh was 5.1%. Can also be expressed as, in 1999, 51 cases of diabetes per 100,000 residents over 20 years of age in the state of Himachal Pradesh. So it's more comprehensive, very clear, and you cannot play around with that statement anymore. So, right? Good, very good. What is written in right? The rate. Although the latter term is often used, the terms such as prevalent rate or autopsy rate are technically incorrect, although commonly used. So you have to just say prevalence. Okay, just prevalence. Okay, keep that in mind. That's one of the trick questions that people ask in an exam is prevalence a rate? No, prevalence is not a rate. It's a proportion that we are calculating, but only we are looking at the time frame, which is a part of the process. So the questions of different ways of how we look at prevalence. One is the question you ask is asthma. If you ask the question, do you currently have asthma? Then that's a point prevalence. When you say, do you have asthma during the last 12 months? That's period prevalence. And did you ever have asthma? It's a cumulative effect, right? So when we use the word prevalence, you need to further dig down and say, what kind of prevalence are you trying to collect? Incidence. So you've already answered this question. The number of new cases of disease that occur during a specified period of time divided by the number of persons at risk of developing the disease during that period of time. It can be helpful to determine the causes of disease can be used to determine the likelihood of developing a disease. Again, the formula is very similar, except that in the numerator, we only take in new cases. In incidence, the denominator includes only disease-free or those individuals at risks and excludes people who are pre-existing cases or unable to get the disease. Whereas in prevalence, it's also included in it, okay? Because they are old and new cases, both included in it. So that's the stark difference that one has to register as it comes to prevalence and incidence, okay? So let's take this a little, I really like this example. A study in 2002 examined depression amongst persons with dementia. The study recruited 201 adults with dementia admitted to the long-term care facility. Of the 201, 91 had a prior diagnosis of depression. Over the first year, 7 adults developed depression. What is the incidence rate? Where did you come up with 110? Spot on. Yeah, absolutely right. Yep. Good. So the year one in 2002, the incidence of depression amongst adults with dementia was 6.36% in the long-term care facility. Okay. This can be also expressed as in 2002, 64 cases per 1,000 patients with dementia in the long-term care facility. So here is something which, in terms of incidence, in terms of incidence, we are comparing two populations. Population 1, we collected data on January 1st, 2001. Population 2, the same, as it relates to diabetes. We found that there were 250 people in both populations with diabetes, and there were 750 people without diabetes. So when we look at the prevalence rate, it's 75%. It's equal. There's something not sitting right. These numbers are not sitting right in terms of the prevalence. It's for prevalence, fine, we can accept it. But what does the incidence tell us? The prevalence of the population between the two populations, you go back in time and then compute the numbers. In 1999, in population 1, there were 50 that were diagnosed with diabetes. And in population 2, there were 150. And when we look at the base number, there was 950 in the first population without, and 850 in the other. And then when we calculate the prevalence differs. 5% in the first population, 15% in the other. So the question we ask is, which population has a higher incidence rate of diabetes in 1999? Population 1, ready to bet? Going 1, going 2, going 3? Yes, you're right, population 1. So when we look at population 1, there were 200 cases after 1999, and people at risk was 950. In population 2, it was 100 cases. And the population at risk was 850. When we calculate the rates between the two, it's 0.21% for population 1 and 0.12 for population 2. So population 1 had a higher incidence rate of diabetes as compared to population 2. Okay. So we have done attack rates. I'm not going to go through this over again. Sometimes we have to look at the data where we stratify the data based on sex. We can do this based on sex, based on occupation, based on level of education, or other different ways of looking at it. So this is generally utilized when we are looking for specific diseases. That's where we tend to look for attack rates in gender. So here is an example which shows the attack rate in women was 45%, whereas in men, the attack rate was 16%. I think this was a study that was done looking at the number of cases of upper respiratory illnesses in women working on dairy farms. Because the women who work on dairy farms are the ones who clean the farm, put the feed in, and there's a lot of dust that is generated. So they were at a higher risk, and therefore the attack rate was higher in women as compared to men. Okay? So that was the hypothesis that was generated based on these numbers. So there are certain frequently used measures of mortality. Okay? So in any given country, if I am supposed to go and visit a country, I will really look at two numbers for that country. And what will be those two numbers? There'll be two numbers that you always will look for a given country. The US government says, Bhushan, you're going to Uzbekistan for 3 weeks. Okay. I have a project, I'm going to Uzbekistan for 3 weeks. But the first thing I will do is I need to know two numbers. What are those two numbers? Population and what else? In terms of the health of the country, let me reframe.
Case specific data. Case specific data.
Case fatality. Looking at two basic numbers is infant mortality rate and maternal mortality rates. So countries with the lowest infant and maternal mortality rates tend to have better healthcare systems as compared to countries with higher infant and maternal mortality rates. So it gives you a kind of a preview how the government is doing in terms of its population. Okay? So those are some of the things that you can quickly check on your phone and say, oh, this is Uzbekistan is ranked 97 out of 167 countries. So you know, I better be careful about my health, although this is infant mortality or maternal mortality. But overall, the health system does not meet the expectations of addressing mortalities in vulnerable populations. Yeah. So there are many different measures of mortality. I will not go through them. And it depends on what you would like to use for a given study. And it kind of tells you what goes into the numerator and what goes into the denominator, and the typical n that we tend to use to compute the rates. Okay? So here are what we call as examples of mortality rates. The first one is we are looking at unintentional injury specific mortality rate for the entire population. That means unintentional injuries can be other than suicide. Falling from a train, falling from a bus, falling from a ladder, it's unintentional. Okay, yeah. So the rate here is the number of unintentional injuries for the entire population divided by the mid-year. So here in this case, we had close to 106,000 cases as compared to close to 2.8 million people. The unintentional injury rates was 37 unintentional as compared to that. Then what do? We find this for the entire population, but this is not truly reflection because people who are very active, mobile, have more physical activity, tend to be at a higher risk of coming down with unintentional injuries. So which is that age group? That age group is between 24, 25, and 34, right? So let's focus on this particular, 44. So what do we do in this case group? We are seeing the number of unintentional injuries increase to 103. So it largely says where you would like to do an intervention, not across the entire population, but focus on an age group that is at a higher risk of coming down with unintentional injuries. Then we can also calculate based on mortality sex specific. So we can calculate the rates. Here the rates are 846 deaths per 100,000 males. So when we look at unintentional injuries amongst the males in that group was 47.7 unintentional injuries. So it clearly tells us different sets of information and how best we can use it. With that, I will stop here. Yeah. In that particular gender. Yes. But let me go back. Yeah, what are you're talking about here? Here, what they have done is, this is just male. The male population was this much. And these were the number of male populations that had developed, unintentional injuries or the deaths occurred due to unintentional injuries. So when we calculate, it was 846 deaths per 100,000.
What is the ratio and case
Which one?
case ratio?
This one? Death to case ratio. One minute. So, one second. No. Case fatality here. So let me first explain you what case fatality is. So the numerator consists of individuals that are severely sick or hospitalized, but in the denominator includes individuals who are sick with the same disease, but have not gone to the stage where they are classified as severe or dead. We can use that for specific deaths. You can apply that to COVID-19 and say, I can calculate the case fatality rate for COVID-19. So the death to case ratio is the number of deaths assigned to a specific cause. Yes, but cause specific. The cause can be usually associated with a condition or a disease. Whereas when we talk about case to death ratio, the number of deaths assigned to a very specific, it is not assigned to a given specific cause. It is more generalized.
Assigned to a specific.
Assigned, yes, number of deaths assigned to a specific cause during a given. Oh, got it. Okay. So let me make a correction here. Death to case ratios are not used anymore. They're not used anymore. The ones that we use are the crude, the cause specific, proportional mortality, neonatal, post-neonatal, infant and maternal mortality. That's a very old term that we tend to use because they're still available in some journals. That's why I placed it. But we hardly use it anymore. And especially when we look at the number 10 raised to n is only 100. Okay, so in those cases, that particular definition just truly cannot apply, but people have used it in the past. That's why I presented in the slide set here. Are you still not clear?
Specific death rate. Suppose if we take example of tuberculosis, how many admitted, how many died? Suppose X that is numerator, Y is denominator. X that is death, Y for the number of.
So are you talking about death to case ratio?
Specific death rate.
Yeah, you can take any disease. You can take any disease or any condition. There has to be from the same population.
But again, that is rate.
Yeah, that's a rate. Yes. Yeah, go ahead.
Prevalence. So for example, I have collected 500 samples of weight. I have isolated salmonella. I got some 50 salmonella from that.
Okay.
So my denominator would be 500. Numerator would be 20.
Right.
50 water.
Right.
Figure.
Right.
So whether it is prevalence, whether it is point prevalence, or it is sincere occurrence or detection rate.
So when we look at the samples, we then have to ascribe, when you use the word sample, what kind of sample is it? Is it a convenient sample? Is it what we call as systematic sample?
For example, I have estimated some sample size.
Right.
Based on that, I have done this study.
Yes.
I will get
You'll get a prevalence of salmonella. It's a point prevalence. It's a point prevalence if you're collected within a small time interval. But the problem here is you cannot extrapolate your number to say that for a large population, because it is, as you rightly said, this is convenient sample. Convenient samples are notoriously used to make inferences when they cannot be done. For example, if there are 10 markets in the city and you sample all the 10 markets over a period of time, and you know it serves the population size of so and so, then that becomes a very important way of calculating the prevalence rates or the prevalence.
single sampling. During my study, I have done only single sampling.
Right,
Now I have done it for a year.
right.
Every month, I have collected samples from 10 different
Markets.
places.
Yeah, okay.
Then I have some figures.
Right.
It will also be a point prevalence.
It will not be a point prevalence. No, it's not a point prevalence. It is.
It will be a prevalence or a period, given period.
You can also call it as incidence, because one sample is not related to another sample. It's not the same cow from which you go and collect another sample, right? Each sample is an individual sample by itself. So you're calculating the incidence time 1, time 2, time 3, time 4, time 5. It's not like you're using an older sample and retesting it and then putting that back into the data. Incidence. Yes. Yeah, it's incidence. Yeah, I'm sorry. Mm-hmm.
Taking it for any
Mm-hmm. Right.
from January to July, we are collecting.
Mhm.
Out of 10, they are collected for retention infections.
Right.
How to calculate and what will be the term?
The incidence. Incidence. Yeah, the incidence of the disease, because once you collect, you're not going back to the same rat to collect a sample, right? It's an incidence. Yeah. I think there is nothing. Is there anything on the chat?
Point prevalence and
Already.
It's the same, a point in time. It's a point in time. Yeah.
Already.
I've responded to that. I said yes. I've responded yes to that. Yeah.
Sir, one more question.
Yeah.
When we are screening some food samples, many a times while screening the literature, some people are using the term occurrence. Some isolation is there. From food sample, we are isolating Salmonella, E. coli, or foodborne pathogen. Some papers are mentioning it as a occurrence, and some are mentioning it as a prevalence.
Okay, so let's see if the definition of prevalence in true terms means old and new.
It's not.
It is not.
Not.
It's a single sample. Now, the next is, in order to make meaning out of it, is it a systematic sampling? If it is not a systematic sampling, it's a convenience or a random sampling, or there's another word that I like to do. It's called a snowball snap. Okay, so when we use these terms, and if somebody puts that in a research grant and says, we did a convenient sample and we found this percentage, and now I'm proposing to do this, it will be very difficult for me to justify and say whether he has found 5% of the samples that he examined positive for a given pathogen. How is he going to then extrapolate that information to develop a full-scale sampling study? So he has to then develop approximates at 5%, 2%, 7%, 10%, and 15%. and say, if I manage to collect a sample in a systematic way, the percentages that I'm going to range is anywhere between 2% to 50%. That allows him to capture the entire 99% of the data points, right? That becomes important. If he has not mentioned it and directly goes and says the prevalence is 5, I'm going to be using it to calculate the sample size, I'm shooting myself in the head. Will your sample size be correct? If you said with the convenience sample of 50 samples I took in my village, and I found the incidence to be 5, now I'm going to look at my district level to see the infection rates. It's like flipping a coin and say, okay, yeah, I agree with you or I don't agree with you. So those are some of the things that we need to be very careful, especially when you're planning to conduct an epidemiologic study or a surveillance study. It becomes very important to look at the numbers and how you present it, because your interpretations and outcomes will be totally screwed if you start using convenient samples to generate hypotheses. That's not the purpose. It is to give you an indication to say how I develop a better study. The next phase where I get more reliable data, which I will use to take it to the next level. So it's in phases that we typically tend to do, and many publications nowadays get rejected if you do convenient sampling. And then they start putting confidence intervals around it. What's the confidence interval between a convenient sample? It has no value.
And so if we use like we did in Permani, we selected Marathwada region, selected the 3 districts. In that there are several talukas. So what we did, we just asked that Equitum software to give us a selected taluka. So we got a selected talukas. So from that selected talukas, again there are some villages within. So within clusters. So what again we submitted the data of that, and we got that points also from where we have to collect the sample. Now within a period of a 4-month of a period, from the 3 districts, whatever the point of a sample collection was, we got from the software. From there, we collected the samples. Now, again, just a 3-month of a period, we collected the samples, we analyzed it for a sample. Around 300 samples we screened out. We got nearly 5 samples of a positive. So now, again, the question will, shall I write it as an occurrence or incidence or prevalence?
It is more indicative of an incidence. It's a one-time sample.
One-time sample. So I should have to write the incidence.
Incidence of the disease.
Sir, is that
Yeah.
We are not isolating it from any clinical case. We are isolating it from food material.
Yes.
The organism is isolated from food material.
Right.
So shall I say it as a prevalence or incidence? Or I should use the word occurrence?
It's up to you, whatever you want to use. But if I were to be using, I would say incidence. For example, let's do another way of looking at it. There are 100 cows on a farm. You go in the month of January, you do colorectal samples and you pull. In some you find salmonella, in some you don't. You go back again and then you find, oh, out of the 100 cows that I examined, 20 were positive for salmonella and 5 of them are again positive for me in the second month. So what is that? That's prevalence. So you can present the data accordingly and say prevalence becomes important because you have done the repeated sampling on a given unit over the time period. Okay? Whereas if you do just one single sampling, either it's point prevalence or it's incidence. So whatever you would like to say, you like to call it point prevalence or incidence since it's just one sample. I prefer to call it incidence rather than prevalence.
We measure this incidence and all. There is again a concept of animal per year. How many number of animals you observed?
I will be talking in that in sampling. I'll be covering that in the sampling aspects of it. Yeah. Okay.
Online.
For online participants, any questions if someone want to ask? Okay. Sir, there is one question. Do incidence and attack rates have the same meaning?
Yes.
Yeah, answer is yes.
Answer is yes.
Anybody else? Okay. If someone is having, they can put it in chat box and sir can answer it afterwards even. So tomorrow.
Tomorrow. I think.
So shall I declare?
Yeah.
So today we are coming to the end of one more question is there. Difference between the formula of virulence and case fatality rate.
It is the same.
It's the same. Okay. Okay.
Yeah.
Okay, friends. Coming to the end of the today's session, and we will be joining Dr. Jarav sir today tomorrow morning at 10 o'clock.
Yeah.
Yep. Thank you. And here we declare that today's session is over. Thank you.
Tell the person that's Dr. Prajapati that it's the same.
Yeah. Dr. Prajapati asked a question that what is the difference between mortality rate and case fatality rate? And the answer is the same. Thank you.
Case fatality also includes dead people. It does